யாழ்ல இது சிஎம்இ ஜாயின் பண்ண. ஆமா, நேத்து அப்படிதான் ஆச்சு எனக்கு. ஏன்பா எனக்கு தெரியாது.
Hello. Yeah. Slide போடு. யாருங்க? யாரு? யார் பண்ற? ம்.
Start பண்றேன். Good afternoon all. Good afternoon Murugan sir.
Sir, good evening, sir.
Good evening. Good evening.
Good afternoon.
Yes. Good afternoon, sir. Good afternoon, Suresh, sir. Good afternoon, Senil, sir.
Good afternoon.
Yeah, I think it's already time we can start the meeting, sir. Murugan sir, can you start the meeting, sir?
Yeah, please go ahead. I am waiting.
Yes, sir. Yeah, a very good afternoon to all the participants of today's CME. So today is the third day of the CGP State Conference of IMA Tamil Nadu. First 2 days we had extensive discussion and there was a lot of following. We are very thankful for that. And today is a very good topic for the general practitioners, both hypertension and diabetes. And we have a very good panel of speakers like Murugan sir, Kumaraveli sir, and two others. Murugan sir will be coordinating today's event. I request our CGP chairman, Dr. Senthil, to give his welcome address. Dr. Senthil.
Thank you, sir. So it gives immense pleasure to welcome you all for the day 3 of 5-day online conference. 5-day online conference. And I think we'll be having a wonderful academic feast by our moderator and speaker for the day, Dr. Muruganathan sir. So we are all eagerly waiting. We'll go straight to the program. Now I request Dr. Tirumurthy sir, Morning Council member, to give IMA prayer and Fission prayer.
Good evening, sir. IMA prayer, sir. May
May
everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May everybody be free from sorrow and may we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, though great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to the life, at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of child I rely on thee.
Thank you, sir.
Thank you, Tirumurthy sir. Thank you for your physician IMA prayer. Now I request our the chief guest for today to give their felicitation. First, I request Dr. Gunasekaran sir, our National Vice President, to give his felicitation. Dr. Gunasekaran sir.
Yes, good evening, everyone. Respected Dr. Senthil Kumar, the chairman of the IMA CGP and the joint secretary of IMA CGP headquarters. Dr. Anand Sukkalingam, the secretary, and Dr. Muruganathan, today's moderator, and our medical council member, and the past president of API, and also past president of IMA Tamil Nadu, who is the authority in hypertension today. Everywhere is spreading the message of hypertension management, and also how to measure and how to take the BP monitoring in the home. Also, wherever he is going, he teaches to our members. I am very much happy, and also Dr. Kumaraveli is there in diabetology. And I am very much happy that the 5 days program, online program, is very much useful for our members to know about the different topics, learn about different topics today, and also the final day at Kodalachi we are going to have. I wish all the success for the CME program by IMA CGP of Tamil Nadu, state chapter. Thank you very much for the wonderful program, and I wish all the success. Thank you.
Thank you, sir. Thank you for your kind words, sir. Now I request our CGP National Secretary, Dr. Anburajan sir, to give his words of felicitation.
Yeah, I think Dean is also joined, sir. I request Dean Dr. Satyajit Bora, sir, to give his felicitations for this program. Thank you, sir.
Yes, sir. Welcome, sir, Dr. Satyajit Bora, sir, our Dean IMA National Headquarters. Welcome, sir.
Thank you. Respected IMA National Vice President, Dr. Gunasekaran, sir. IMA CGP Headquarters Secretary, Dr. Anburajan. Tamil Nadu CGP State Director of Studies, Dr. Santil Kumar, the State Secretary, and all the delegates present here. And I am very fortunate to see Dr. Muruganathan sir here. He will be the main attraction, star attraction of today's program. And I bring greetings to all of you from the CGP headquarters. I also pay my regards to the State President, Dr. Abu Hassan, and the State Secretary, Dr. Kartik Prabhu, both of our very good friends. And it's really a pleasure to see the online programs organized by the IMA Tamil Nadu CGP State Faculty. The delegates are joining in lightning speed. Already there are more than 400 delegates joining, and I strongly believe this will exceed up to, I think, maybe 700-800 or more than that. And we get inspiration from this type of online programs for other state faculties also. And I have been attending many programs organized by Tamil Nadu State Faculty, and I'm really proud. They are the pioneer state faculty in the whole CGP in the country. And this annual academic fiesta, they are organizing with a 5 days program with excellent topics like infectious diseases, diabetes, hypertension, vaccination, animal bites. Those are very important. And for the general practitioner, I believe all the GPs who are joining here, all family physicians, they will go back with enriching their knowledges. And all of us know that GPs are the main caretaker of the public health system of the country. So I believe they will be going back with enriching their knowledges. And I wish all this 5 days program, already 3 days are gone, grand success, including the physical program on Saturday. I'm very unfortunate I could not be there physically, though I have a very strong desire to be there physically in Polachi. And with all these few words, I conclude my speech. And thank you, everyone, and wish you all the best, all the delegates and all the faculties. Thank you.
Thank you. Welcome, Bora, sir. Gunasekaran here.
Thank you.
Yes, sir. Thank you, sir. Thank you, Dean, sir, for your kind words. Yesterday, there are about 850 to 900 online, sir. The day before yesterday, it was between 950 and 1,000, sir. Today, it will be more than that, sir. So thank you for your kind words of encouragement. We will try to keep up the same, sir. Thank you very much, sir. Now I request Dr. Anburajan, sir, our CGP National Headquarters Secretary, to give his words of felicitation.
Being very happy to say that the Tamil Nadu IMA CGP, the faculty of Tamil Nadu CGP, is doing very well in conducting the CME program. And this 5 days program for the general practitioners of our countries has brought a very good and interesting, things that the general practitioners has to learn in their life. So I congratulate the chairman Senthil Kumar and the secretary Anand Shukkalingam for conducting this kind of program very effectively. As I told you earlier, among the all states, Tamil Nadu state is doing such kind of CME activities very effectively, and number of people joining and getting benefited are also very high. So dissemination of knowledge through this proper channel to all the needy general practitioners has been done very well by Tamil Nadu faculty. And I also thank our dean who has taken some efforts to join this, and also the national vice president Dr. Gunasekaran also has joined this day's function. So this CME program, first day infectious disease and vaccination was done very well, and more than 1,000 participants were there. And the second day obstetrics and fetal medicine also likewise. So today, diabetes and hypertension, which is a very important, thing that we have to know what is new and what are all the things that we have to be keen on seeing patient. As the India is becoming a diabetic hub of this world, now it is pertaining to the need of our general practitioners. This topic has been made. And then Dr. Muruganathan is the very genius person in handling this kind of topics, and is a very good teacher that he will be teaching in a better way that everybody will learn the reason things what we have to know in each of the in both diabetes and hypertension. So his moderation will be of much useful, and I also congratulate all the speakers going to speak on hypertension in pregnancy, diabetes in pregnancy, musculoskeletal manifestations of diabetes, and the 4 pillars of the heart failure. Very excellent topics were being selected, which would be definitely very much useful for those who are attending the CME today. Best of luck. God bless you all. Thank once again for the opportunity given for me.
Thank you, sir. It was very kind of you, sir. Sendil?
Anburajan,
Yes.
welcome, Anburajan.
Sir,
I didn't recognize you.
thank you, sir. Thank you, sir.
So with help of and guidance of all our national CGP leaders and our state president secretary, we are able to do this much, and we'll try to continue the same, sir. Thank you, sir. So now we go into the program directly, and our first speaker is Dr. Muruganathan, sir. So he needs no introduction, but in short, there is chairman, standing committee of hypertension, Tamil Nadu, past Dean, National CGP headquarters, and past state president, IMA, Tamil Nadu. Welcome you, sir, and the session is yours. Kindly continue, sir. Thank you so much.
Thank you very much, Sendil, for giving me this opportunity. My respected, my close friend and brother, Dr. Gunasekharan, Dr. Satyajit Ray, the Dean, the Anand Chokalingam, and all my Anburajan, and all my good brothers and sisters. In fact, today, this program is happening because of Sendil's perseverance and, continuous, follow-up. I think we must give a great appreciation to Sendil, because whenever he takes a job or task, he is very particular that things should get better. He first said, you will be the speaker. Then slowly he said, you will be the moderator. Then he said, you will organize all the speakers. So literally he made me do this program without hurting me. So that's the nature of the leadership. And I chosen 4 good speakers. Not 4, only not me. Well, other 3 speakers are very good speakers who are very, very well talented and great academicians. And we have selected the topic because, one thing the lady doctors also should be interested. That's why we've chosen pregnancy hypertension, pregnancy diabetes, and then the geriatric people who have got sarcopenia and musculoskeletal problem due to diabetes. That's all the common problem which we normally don't discuss. And 4th one was the 4 pillars of cardiac failure, because every general practitioner, family physicians get, edema, feet, cardiac failure. So how to handle, how to do these programs. That is why we have chosen this topic. I'm sure you will really enjoy. And also Sendil will give the link after the program. So those of you who have not come, you can also have the link so that you can leisurely watch at home. I also take this opportunity to invite and welcome our good friend, my friend, Dr. Gunasekharan, Dr. Satyajit, for our Tirupur IMA new building inauguration on 14th. Our national president is coming, state president is coming, Anburajan. Please join us we'll be very happy if you come to Tirupur. So with this, I'll start the topic. The topic is hypertensive disorders in pregnancy. What is my plan? First is diagnosis and classification. The second one is pathophysiology. I will not deal more about pathophysiology because it may be a little dry. So I'll give a short pathogenesis, then evaluation of newly diagnosed hypertension, and then investigations to diagnose severe disease early, management, and conclusion. This is my roadmap. The most common medical complication of pregnancy is this, diabetic hypertension. Hypertension pregnancy. 18% of the maternal mortality. In India, as a group of hypertensive disorders of pregnancy, is reported to be 12 to 22% of the pregnant women. The incidence of preeclampsia was found to be 10.3. This hypertensive disorders of pregnancy is not only bad for the mother, it is also bad for the fetus. As per WHO, the lethal trifecta of pregnancy, hemorrhage, hypertensive disorder of pregnancy, and infection claim the lives of at least one woman every 7 minutes. When estimated 62 to 77,000 deaths each year, hypertensive disorder of pregnancy account for approximately 18.1% of maternal mortality. So as I said, both mother and the fetus are at the risk. That is why the maternal risks include placental abruption, stroke, pulmonary edema, thromboembolic events, and multiple organ failure at DIC. Fetus, intrauterine growth retardation, prematurity, and intrauterine death. That is why this topic is very, very important, and you will have to do a lot of screening and monitoring for preventing this dreaded complication. Hypertensive pregnancy is based on office BP value. More than systolic blood pressure 140 or diastolic more than 90 is classified as hypertension pregnancy. You must know one important thing. This hypertension pregnancy, whether before 20 weeks or after 20 weeks. You please remember that 20 weeks. Again, the hypertension pregnancy is divided only into mild and severe. There is no moderate. 140 to 159, 90 to 109 is mild hypertension pregnancy. Severe is more than 160 by 110. Again, this hypertensive disorders of pregnancy are classified into pre-existing chronic hypertension. What do you mean by that? Somebody who is hypertensive get pregnant. So the hypertension continues during pregnancy. So pre-existing hypertension or chronic hypertension, this can be due to primary hypertension or secondary hypertension. Secondary hypertension due to kidney disease or congenital heart disease and things like that. All the endocrine, our friend, my subsequent speaker who is an endocrinologist, there are so many causes of secondary hypertension, primary aldosteronism, Cushing, etc. And weight coat hypertension and mask hypertension. I will define what is weight coat here itself. The weight coat hypertension, the patient will have elevated BP in the clinic. We always say clinic, not office, but anyway, elevated clinic or office BP, whereas they will have normal BP outside office. The masked hypertension is opposite. When the patient comes to you, it is normal. But when the patient takes blood pressure at home or other environment, it is elevated. So how do you diagnose this weight coat and masked hypertension? Only with out-of-office BP measurement, and most useful instrument is home blood pressure monitoring. So every physician, every family doctor must educate the patients about the use of home blood pressure monitoring. Fortunately, people are aware about home blood sugar monitoring, but not home blood pressure monitoring. So we would like to promote the concept of home blood pressure monitoring, especially in pregnancy. Okay, how do you diagnose clinically when somebody comes with masked hypertension? You always check the pressure. The pressure is normal at the clinic. Whereas the patient may have hypertension-mediated organ damage. What is that? They may have eye changes, retinopathy, or they may have microalbuminuria, or they may have left ventricular hypertrophy. So somebody whose BP is normal, but they have a target organ damage, then you suspect masked hypertension, and then you submit them for home blood pressure monitoring or ambulatory blood pressure monitoring. Then you can diagnose masked hypertension. And of course, the second one is gestational hypertension, transient gestational, and preeclampsia. I'll define a little later. Pre-existing hypertension, superimposed preeclampsia. What is that? A person has got hypertension, continuing pregnancy. After 20 weeks of pregnancy, the hypertension becomes resistant, lot of complications, problems. This is called superimposed preeclampsia. Hypertension with superimposed preeclampsia and antenatally unclassified hypertension. I will define one by one. And most important, the measurement technique. Our friend Gunasegaran was talking. How to measure BP accurately is very, very important. Especially in a woman who is pregnant, if you want to take the blood pressure, the sitting pressure is okay. If not, left lateral recommend position. And how to take the blood pressure itself, I think you would have learned it from many people. Patient should be calm, relaxed. You should not take the pressure as soon as they walk in. Give them 5 minutes rest. They should not have urge to pass urine. They should have taken coffee and things like that. One important thing is, if the blood pressure is more than 140/90, when you check the pressure, confirm with second reading after within 4 to 6 hours. If the blood pressure is more than 160/110, you have to confirm the reading within 15 minutes. There is a nice article about how to measure blood pressure in pregnancy. Now, I'll talk about first classification, chronic hypertension. What is chronic hypertension? A known case of hypertension or a case of hypertension detected before 20 weeks of gestation. Remember this 20 weeks. If somebody has got hypertension before 20 weeks of gestation, in the absence of neoplastic, tropoplastic disease and multiple pregnancy, then this is a chronic hypertension. And then when you have chronic hypertension, again, check for what is the blood pressure. If it is more than 140/90, you look for comorbid conditions like pre-gestational diabetes or kidney disease. Why you have to check for the comorbid? If they have a comorbid condition, you need tighter BP control because of their association with heightened cardiovascular risk. And if you see, as I said, evidence of preeclampsia, what is that? This is also known as superimposed preeclampsia. If the patient develops one or two of the following things, like after 20 weeks, they have hypertension, all right, but after 20 weeks, they become a resistant hypertension or new or worsening proteinuria, one or more adverse conditions or complications, then you have to suspect chronic hypertension with superimposed preeclampsia. What is the gestational hypertension? I already told you. The blood pressure is more than 140/90, detected beyond 20 weeks. Make a point. Detected beyond 20 weeks and also returns to normal within 42nd of postpartum day. The blood pressure will become normal within 42 days. If they don't become, then it is a chronic hypertension and is not associated with any other feature of preeclampsia. I've already told you how to measure blood pressure and what is the time duration required. And gestational hypertension, again, first time after 20 weeks, you also look for comorbid in this condition also. Then what is preeclampsia? Preeclampsia may arise de novo. It may come de novo, or it is defined by gestational hypertension and one or more of the following: new proteinuria, one or more adverse condition, one or more severe complication, and severe preeclampsia is defined as preeclampsia with one or more severe complications. I'll classify preeclampsia also. Preeclampsia can be classified into early onset preeclampsia and late onset preeclampsia, and also mild preeclampsia and severe preeclampsia. What is early onset of preeclampsia? The preeclampsia occurs before 34 weeks. This is more dangerous than the late onset of preeclampsia, which develops after 34 weeks. And then the classification of 4, I told you, transient hypertensive effect may be due to environmental stimuli or the pain of the labor, and it can be white coat hypertension or mass hypertension. When the BP elevation is non-severe and a preeclampsia is not suspected, ambulatory blood pressure or home BP monitoring should be submitted. Now, I'll give you an algorithm. I told you blood pressure is more than 140/90. Just see less than 20 weeks or more than 20 weeks. If they're less than 20 weeks, if the BP is high in the clinic or normal in the clinic. So it depends on that, masked or white coat hypertension. If there is no evidence of the preeclampsia symptoms, it's just a chronic hypertension. If there is a symptoms like dyslipidemia, proteinuria, abnormal ECG, abnormal liver function tests, etc., then you look for chronic secondary hypertension also. If the blood pressure is more than 140/90 after 20 weeks, it can be simple gestational hypertension. Or if you have these following: proteinuria or uteroplacental dissection neurological complication, etc., then it becomes preeclampsia. If there is no other complication, just a gestational hypertension. If it is only transient, so transient hypertension. So this is the diagnosis of algorithm. So I've already told you blood pressure more than 140/90, and then it should be before 20 weeks or after 20 weeks. If it is before 20 weeks, you have to rule out chronic hypertension. After 20 weeks, if the patient has got any development of proteinuria or any complications which I mentioned, like neurological complication, headache, hematological complication, then it becomes a preeclampsia. The patient may have hypertension with preeclampsia, superimposed preeclampsia. So these are the main classification. Pathophysiology I will skip because pathophysiology is mainly because of the abnormal spiral artery which supplies the placenta, and also there are a lot of immunological factors, the angiogenic progenic imbalance and substances which can cause these hypertension in pregnancy. There are a lot of theories, the SGPLT, tyrosine-like substance, all those things are there, but I think for want of time and I don't want to give too much of sort about pathophysiology. I can answer questions if you have any doubt on pathophysiology. Now I'll go to evaluation of hypertension. I told you it can be chronic versus gestational. Chronic hypertension versus gestational. Again, whether it is gestational hypertension, are we dealing with gestational or are we dealing with preeclampsia? Okay, if you are dealing with preeclampsia, are we dealing with mild preeclampsia or severe mild gestational hypertension or severe gestational hypertension, or mild preeclampsia or severe preeclampsia, or preeclampsia versus eclampsia? Now I'll define and explain everything one by one. When you suspect gestational hypertension or preeclampsia, usually patient's age is around 20. In chronic hypertension, older people. Here, primigravida, here multigravida. I told you onset 20 weeks of pregnancy. This chronic is before 20 weeks. Weight gain is sudden. Here it is gradual. And fundoscopic finding, very important. I request every one of you to learn fundoscopy in your OP so that you can rule out spasm. If you there or edema, it is preeclampsia or gestational hypertension. There in chronic hypertension, it is arteriovenous nicking or exudates. Proteinuria may be present or may not be present. Even without proteinuria, you can diagnose preeclampsia, whereas usually in the chronic hypertension, proteinuria is absent. Another important biochemical investigation is plasma uric acid. When the plasma uric acid is increased, then it may be preeclampsia. Here in chronic hypertension, it is normal. And then plus blood pressure after delivery becomes normal gestational, whereas it's elevated in the chronic hypertension. I told you mild and moderate, mild and severe, there is no moderate. And then now, how do you differentiate gestational hypertension whereas preeclampsia? The gestational hypertension, primi, not a strong risk factor, whereas preeclampsia, primi is a strong risk factor. Recurrent risk 20 to 47%, whereas in preeclampsia, recurrent risk is 5%. Total blood and plasma volume not low in gestational, whereas total blood and plasma volume is low. Proteinuria is absent in gestational, it is present in preeclampsia. Edema absent, edema present. No adverse conditions or complications in gestational. Adverse conditions and complications are there in preeclampsia. And how do you diagnose preeclampsia? When you do the 24-hour urine collection, there will be more than 300 milligram of the protein. Our protein creatine ratio is 0.3. And in the absence of proteinuria also, with new onset of hypertension, with the new onset of any of the following complication, you still diagnose as preeclampsia, like thrombocytopenia, platelet count less than 1 lakh, renal insufficiency, then pulmonary edema, new onset of headache, unresponsive to medication, and not accounted by alternative diagnosis or visual symptoms. If any one of these symptoms are there, then you think of preeclampsia. You can see there may be visual disturbance, dyspnea, chest pain, right upper quadrant pain, low urine output, and pregnant women with these symptoms should be suspected to have preeclampsia, even when there is no proteinuria and severe edema. So these are the symptoms of preeclampsia. So look for any problem, right upper quadrant pain, or low urine output, or headache, visual disturbance, things like that. Now, The systolic blood pressure is more than 160, 110 on 2 occasions with few minutes, then antihypertensive therapy is initiated. Thrombocytopenia, already told you. There will be impaired liver function test. And you can see renal insufficiency, pulmonary edema. I already told you new onset of headache, visual disturbance. Now, what are the adverse conditions? What are the severe conditions? The adverse conditions, I told you, the central nervous system, headache or visual symptoms. The severe thing is eclampsia or posterior reversible encephalitic syndrome, cortical blindness, and then stroke, etc. In a cardiorespiratory, there will be chest pain, dyspnea, and oxygen saturation less than 97. And here, uncontrolled severe hypertension and oxygen saturation less than 90. Then, hematologically, elevated WBC count, low platelet count. And here, renal, elevated creatinine, elevated serum uric acid, nausea, vomiting, right upper quadrant pain, low plasma albumin, hepatic dysfunction, hepatic hematoma or rupture, and fetoplacental non-reassuring FHR, IUGR, abruption with evidence of maternal pitch complications. These are the adverse conditions and severe complication. If suppose somebody has this with the gestational hypertension, you are dealing with a case of not gestational hypertension, pre-eclampsia. Now, what is eclampsia? A new onset of seizures in a woman with preeclampsia is called eclampsia. So it is a preeclampsia where there is a sudden onset of seizures. It can be preceded by severe preeclampsia, or it may appear unexpectedly in a patient with minimally elevated blood pressure with no proteinuria. So fits or seizures can come in a patient unexpectedly with the pressure not very high also. Blood pressure is only mildly elevated in 30 to 60% of the women who develop eclampsia. It can occur antepartum 53%, intrapartum 19%, and postpartum 28%. Now, in any pregnancy, it is important to decide whether this patient will develop gestational hypertension or preeclampsia in early or late pregnancy. Clinical investigation risk scores to help us. The risk stratification should start around 12 weeks. Look for these risk factors: nulliparity, multiple gestation, preeclampsia, the previous pregnancy, chronic hypertension, progestational, pregestational diabetes, gestational diabetes, thrombophilia, anti-phospholipid antibody syndrome, kidney disease, assisted reproductive technology, obstructive sleep apnea. So if are these assisted reproductive technology and the obstructive sleep apnea, if you have those history, be careful, screen them carefully before they develop problems. And of course, I told you lab urine albumin, complete blood count. Serum uric acid is very important. I tell you about serum uric acid. The uric acid can be a predictor or it can be used for diagnosis or prognosis. The serum uric acid has been long associated to preeclampsia, but its prognostic value is still debated. Evidence is accumulating pointing to a role for first trimester uric acid level as a predictor of preeclampsia, though its accuracy may not be optimal. In the subgroup of women who develop hypertension in the course of pregnancy, serum uric acid is a good predictor of preeclampsia with good sensitivity and specificity. Among women with preeclampsia, serum uric acid levels may help identify those who will develop more severe disease. So it can be predict, it can diagnose, it also gives you clue for prognosis. Of course, ultrasound, ladies and gentlemen, you must do ultrasound, follow up properly. And especially what we know as feto-maternal specialists, and there are good ultrasoundologists who are very good in finding out the congenital malformations, congenital anomaly. And a word of caution: when obstetrician do the ultrasound, please don't mention there is no congenital anomaly if you are not sure. If you think there is a congenital anomaly, you have to send it to the congenital anomaly detecting centers and specialists. And if an ordinary ultrasound, if you don't find, if you give a commitment in the report, if the baby becomes some problem, then you will be sued in the court and you will have a lot of problems. So it's a word of caution. As a medical council member, I would like to emphasize the obstetricians can do ultrasound very, very routinely, clearly. And if you suspect congenital anomaly, or if you think the patient goes for some problem, it is always to get better opinion from experts and don't commit no anomaly, because We get 2-3 cases in our medical council. They say there is no anomaly, but the limb was missing. There are so many things, meningomyelocele, things like that. So I think it's a word of caution for all obstetricians. Be careful when you give this in black and white report. Now you can see ECG will show the electrical changes. Echo shows the mechanical changes. So you just rule out any LVH or any problem due to pregnancy hypertension. Now fundoscopy, I already told you, you have to do differentiate chronic and new onset of disease, papilledema, hemorrhage, etc. Additional imaging, echo, chest X-ray if necessary with shield, MRI of the brain. Neuroimaging is not recommended universally in all cases of eclampsia. And then uterine artery Doppler, because the pathophysiology of gestational hypertension is the abnormal uterine artery modeling. So you'll have to see the uterine artery Doppler analysis in the second trimester, and the studies at 18 to 20 weeks have shown 70 to 80% reduction rate of the late onset of preeclampsia. First trimester Doppler of the uterine artery performs better in the prediction of early onset than the late onset of preeclampsia. So this uterine artery Doppler also gives you a clue who will develop problems. Then PIGF test to predict PET. I told you some substance or good substance called placental growth factor and soluble FMS like tyrosine kinase. This is a bad factor. So you see PIGF test. If the PIGF is normal or high, then the risk is low. So they will not develop preeclampsia. If the PIGF is more, or it's less, they are high risk of developing pregnancy. So by diagnosing PIGF, you can come to a conclusion whether they'll go for preeclampsia. Not only PIGF, the better diagnosis test will be PIGF ratio, PIGF versus SFLT. We call it a soluble FMS like tyrosine substance. It is available. So when you do this ratio, if the ratio is less than 38, they are normal. If the ratio is more than 38 by 110, they may go for preeclampsia. If it is more than 110, definitely they will go for preeclampsia. You should be very careful. So this test is useful. The ratio of SFLT1 bar PIGF. PIGF is a good factor. SFLT is a bad factor. So the SFLT is more and PIGF less, they're likely to go for problems. So ratio is important. Now, there are a lot of apps have come. So many apps have come. So for this predicting preeclampsia, you have GenPIs, full pairs, mini pairs, and so many risk scores pairs have come. So those apps also will give you a clue whether this patient will go for preeclampsia. Now the Obstetric Association, FOXI, has developed a score called gestasis score. What is gestasis score? They find out the obesity, because people with obesity more than BMI 30, they will have a high risk for developing preeclampsia, primigravida, or any maternal hypothyroidism, multifetal pregnancy. When you have these scores, we give marks 1, 1, 1. And if the risk score is more than 3, be careful. You may deal with a case of preeclampsia. So this is called gestasis score. You can have it in your table. Just to tick these risk factors, and then you can decide how to monitor and follow. Then a word about HELP syndrome. What is HELP syndrome? The name itself says H is hemolysis, EL is elevated liver enzyme, LP is low platelet. So hemolytic, elevated liver and low platelet count syndrome is a variant of severe preeclampsia. It is a severe preeclampsia variant, occurs up to 20% of pregnancy, at variable clinical presentation. 12 to 18 are normotensive and 13 do not have proteinuria. At diagnosis, 30% of women are postpartum, 18 are term, and 52 are preterm. But only thing is mortality is high. How do you diagnose? I told you it is a hemolysis. So when you see hemolysis, you can see in the periphery sphere red cell fragments called cystocytes or burst cells. If you see the burst cells or cystocyte, be careful. Look for elevated liver enzyme, low platelet count, and you are dealing with a HELP syndrome. HELP syndrome, mortality is high. I told you the biomarker testing. I told you about the SFLT, anti-angiogenic. It is low in normal pregnancy. Levels are high in preeclampsia. Then PAGF is a good thing. It's a pro-angiogenic. The levels are high in normal, low in preeclampsia. Then kidney injury. The best kidney injury marker is called NGAL. Then ventricle, you can see BNP, the natriuresis normalization of blood pressure. Levels low in normal pregnancy, high in fluid overload. Relaxin. So these are the markers you can see. Now, having diagnosed, having talked about evaluation and the diagnosis, now how do you manage? The aims of the management is to save mother without morbidity and mortality. Again, to save fetus without morbidity and mortality. Of course, to save ourselves, we must be very careful when you deal with a pregnancy hypertension. Now, prophylactic. You should have good education and counseling. I told you home blood pressure monitoring is important. You have to discuss healthy lifestyle choices. A key component of preventing hypertension during pregnancy is making healthy lifestyle choices. Encourage a balanced diet rich in fruits, vegetables, and whole grains. Promote regular exercise as advised by healthcare provider. Maintaining a healthy weight is also crucial. Stress the importance of regular prenatal care. Many people in the rural area, they don't come for regular checkup. They don't even check for the blood pressure. That is why Makkalai Thedi Maruthuvam in our Tamil Nadu government, the nurses go to the home and they check the blood pressure and they give medicines. And that's one way of finding the early blood pressure changes in the pregnant women during pregnancy. Regular prenatal checkups are essential for early detection of hypertension. Then you have to monitor your blood pressure and other vital organs throughout your pregnancy. They can also provide a guidance on diet, exercise, and necessary intervention. A word about the self-monitoring and record keeping. If you have hypertension during pregnancy, you will have to do self-monitoring. I already told you. Keep a record of your BP, symptoms, any change, etc. You write it. And when you visit the doctor, ask them to show the patient record. Mention the role of home BP. I already told you, very important. Now, supporting pregnant individuals, encourage family and community support. Emotional support is very important. In our, families and in our culture, a pregnant woman is very special in the family. Everyone, takes care of them. And, there is a saying, whatever the pregnant mother or a woman wishes, it should be fulfilled. That was the original thought. So you'll have to give a full support whenever they go for a travel, when they go for a bus or a train, preference and priority, the community should take care. Now, to summarize the key points of the importance of prevention, preventing hypertension during pregnancy is essential for a healthy outcome. Key points include early identification, healthy lifestyle, regular prenatal care, importance of medical intervention when needed, self-monitoring and family and community strong support system. Prioritizing prevention is the cornerstone of a healthy pregnancy when dealing with hypertension. So having talked about prevention, I'll go to the treatment part. Of course, I already told you about preeclampsia. There's one more thing, low dose of aspirin, preferably 75 to 150 milligram, started before 16 weeks of pregnancy when you think the patient has got increased risk of preeclampsia. Particularly if any of the following you there, previous preeclampsia, multiple pregnancy, obesity, assisted reproduction pregnancy. In all these complications, it is worth to start 150 milligram low dose aspirin before 16 weeks. And then what are the general measures? Observation, maternal and fetal. Maternal, I already told you, blood pressure twice daily, urine volume, body weight, fundus, blood picture, platelet count, uric acid. Fetus, daily fetal movement count, serial sonography, non-stress and stress test if needed. One important thing, what not to use in the pregnancy. Do not use nitric oxide donors, progesterone, diuretics, low molecular weight heparin. Do not recommend magnesium, folic acid, antioxidants, vitamin C and E, fish oils or algal oils, garlic. No restriction on dietary salt. Some advice for rest, exercise and work. Now, this is the broad algorithm. management of hypertension pregnancy, hypertension pathway, this is preeclampsia pathway. In a normal hypertension, if it is 140/90 or 150/90, do not admit routinely. If the pressure is more than 160, 110, admit. And then if the preeclampsia pathway, again, 140/90, not necessary. If there is a severe hypertension, admit. The choice of tablets are, first choice is labetalol, second choice is nifedipine, the third choice is methyl-dopa. So always aim for bringing the blood pressure around 135/85. Blood pressure you have to monitor once and twice a week. I already told you proteinuria, blood tests, etc., which you have to do. And then if the patient is admitted, you have to check the pressure frequently. Then in a chronic hypertension, the treatment is again, you continue advise weight management, exercise, healthy eating, lower salt. Here only lower salt comes. In a chronic hypertension, you have to give lower salt, continue antihypertensive treatment, and sustain systolic blood pressure less than 120, sustain diastolic blood pressure less than 70. The threshold should be 140/90. Target is 130/85. Very important point, avoid hypotension. Don't give aggressive treatment and then make them have hypotension. Then what drugs? Again, same drugs like labetalol, nifedipine, methyl-dopa. I give aspirin 150 as prevention. Then offer placental growth factor. When the patient is a chronic hypertension, check this PIGF at the PIGF ratio so that you will know whether this patient going for preeclampsia. And then you have to have antenatal appointments frequently. And this is a teamwork. The physician, the obstetrician, the pediatrician, everybody should be there. In fact, I tell you very jovially, I married my wife is an obstetrician. I'm a physician. So we make a good combination, especially in this pregnancy problems, medical disorders in pregnancy. I don't advise everyone to marry only obstetrician, but it's an added advantage. Okay, that's a lighter vein. Labetalol, you give 200 to 1,200 milligram in 3 divided doses. The problem with labetalol, it may be associated with fetal growth restriction. Nifedipine, 30 to 120 milligram. This may inhibit labor and have synergistic action with magnesium sulfate in BP lowering and little experience with other calcium entry blockers. And then third is methyl-dopa, 0.5 to 3 grams in 2 divided doses. This is a very good drug, but unfortunately, this is not a very effective antihypertensive. And nowadays, methyl-dopa is not available in many places. Hydralazine, 50 to 300 milligram. Few controlled trials, long experience with few adverse events documented, useful combination with sympatholytic agent, and may cause neonatal thrombocytopenia. Now, the time of birth in a chronic hypertension, before 30 weeks, you need not plan. If the patient is properly followed, the delivery can safely happen after 37 weeks. And you have to consult the teamwork, all the specialists, and then do the counseling with the patient. The senior obstetrician also should be taken into consideration. If early birth needed, offer steroids and magnesium sulfate if it is indicated. And postpartum follow-up, daily BP checkup after 7 days. Don't relax after delivery. Okay, patient has delivery. I don't need to check the blood pressure. Continue checking at least for 7 days. If the blood pressure is 130/80, continue the same treatment. If the blood pressure comes to 130, less than 130/80, stop the treatment. If the blood pressure is more than 150/100, intensify or restart some other drug. Stop methyl-dopa after 2 days of delivery. Then the management of preeclampsia versus hypertension. I've already told you about hypertension. The admission to hospital is not routinely in a mild hypertension. You have to admit if there is a BP is more than 160. And then antihypertensive drug, I already told you, the threshold I've told you, and blood tests, everything I've told you. This is how you manage. This is according to NICE guidelines. The target is again 135/85. And here in severe hypertension also, only thing you have to admit and make sure you get 135/85. Those drugs you do, routinely you do the investigation. Very important is fetal assessment. Periodically you assess the fetal. CTG only if clinically indicated. Now, predict preeclampsia early. Whenever you think of preeclampsia, the best thing is to prevent it. So in a gestational hypertension, you predict preeclampsia early by using full Pierce or PRIP-S Pierce for the patient, or use gestation score, or full Pierce used any time in pregnancy. PRIP-S cure is used only up to 34 weeks. But both models do not predict outcomes for babies. They can tell you that this patient goes for preeclampsia. Now, the treatment of preeclampsia, again, if it's more than 160, 110, you have to admit. Then high-risk patients, you always follow properly. And the same precautions, same thing what I told you earlier. Now, what is the management of preeclampsia? First, it should be assessed by the trained person. Full clinical assessment, each antenatal appointment. Offer admission if any one of the concerns, like the blood pressure is more than 160, 110, new or persistent hypertension, creatinine more than 1 milligram, ALT more than 70, reduced platelet count, signs of impending eclampsia, suspected fetal compromise, any other clinical concerns, signs that cause concern. In those conditions, you admit and then follow proper monitoring. And then I already told you about aspirin. If somebody has got one of the high risk factor or one or more of moderate risk factor, you give aspirin. That is, if there is autoimmune disease, systemic lupus erythematosus, antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension, they require aspirin 150 milligram before 16 weeks or before 12 weeks. And in the moderate risk, if the patient pregnant more than 40 or family history of PET, one or more moderate risk, start them on aspirin. Now, hypertensive emergency. I just a word of definition. Hypertensive emergency in general, not in pregnancy. We call it as hypertensive emergency in general for a patient. If the patient develops blood pressure of more than 180 by 110, then we call them as hypertensive emergency. We call them hypertensive emergency if there is a target organ damage. If there is no target organ damage, it is called hypertensive urgency. So in general population in hypertension, we classify as hypertension emergency if there is a target organ damage. Hypertension urgency if there is no target organ damage. Blood pressure is 180, 110 more. That is normal. I mean, that is not for the population. In a pregnancy, hypertensive emergency, if they develop even 160, 110, they may have severe complications. Then they are classified as hypertensive emergency, where you have to do critical care during pregnancy. Give one of the intravenous drugs like labetalol, nifedipine oral, or hydralazine. The word about nifedipine, even in emergency, don't give sublingual nifedipine. Sublingual nifedipine should not be used and should not be given. So oral nifedipine and hydralazine IV. Severe hypertension with critical care monitor response, you find out BP falling and then properly monitor in the intensive care. I'll give you the dosage. The IV labetalol or IV nicardipine, IV nitroglycerin or IV nitroprusside. These are the conditions, the drugs you can give in an hypertensive emergency in pregnancy. And the doses of the labetalol intravenous 10 to 20 milligram, 20 to 80 milligram every 10 to 13 minutes, maximum 300 milligram. The outpatient, you give 200 to 2,400 orally. Hydralazine intravenous 5 milligram, 5 to 10 milligram every 20 to 40 minutes. Nifedipine oral 10 to 20 milligram every 2 to 6 hours. And then methyl dopa, not commonly used as a first line in emergency. Of course, 500 to 3,000 milligram may be given and divided in 2 to 4 doses. Now, anticonvulsants, a word about anticonvulsants. Severe hypertension with preeclampsia, who had preeclampsia or preeclamptic fit already, give them IV magnesium sulfate. If you have a history of eclamptic fit in the previous pregnancy, be careful and watch. You can give IV magnesium sulfate. IV magnesium sulfate if birth planned within 24 hours. Consider need for magnesium sulfate if one or more future of severe preeclampsia, that is ongoing or recurring severe headache, visual scotoma, nausea, vomiting, epigastric pain, oliguria, severe hypertension, progressive deterioration of lab blood tests. In those conditions, you consider giving magnesium sulfate. The preeclamptic patient, if these things are there, give magnesium sulfate. Before magnesium sulfate, loading dose of 4 gram for 5 to 15 minutes, infusion of 1 gram maintained for 24 hours. If there is a fit, continue infusion for 24 hours after the last fit. Do not use diazepam, phenytoin, or other anticonvulsants as alternatives. And then for the doses of magnesium sulfate, there is a pre-chart. Loading dose is 14 gram, 4 gram slow IV in 20 ml, 20% solutions. Intramuscular, it can be given 5 gram. Maintenance dose 5 gram deep intramuscular. Then maintenance dose will be given only if the following parameters are present, like respiratory rate is more than 60, petallar reflex are present, urine output is more than 100 ml in last 4 hours. And then when do you do immediate intervention? When there is uncontrolled severe range of blood pressure or persistent headache, epigastric pain, visual disturbance, stroke or myocardial infarction, Alp syndrome, you do intervention and delivery, do the delivery even before 37 weeks. Delivery before 37 weeks can be done when you have these following things, because delivery will be the curative in this severe preeclampsia with emergency. Now, delivery decision, always consult the obstetrician, consult the whole team, pediatrician, everybody, and then come to conclusion. But generally, in a gestational hypertension, pregnancy can be continued till the term. In a mild preeclampsia, it can be delivered at 37 completed weeks. In severe preeclampsia, to be delivered after 34 weeks. In eclampsia should be delivered once mother is stabilized after magnesium sulfate. Labor induction with appropriate method can be carried out safely. Cesarean section is done for obstetric indications. Now, postpartum, what do you do? Daily BP checkup for 7 days. Don't relax in postpartum, because one may have problems after postpartum also. They may have postpartum hypertension also. Ask about severe headache or epigastric pain during every BKV checkup. And if the blood pressure is more than 150, 110, intensify your treatment. Then, of course, the drug treatment during prepartum and postpartum, especially during lactation, labetalol, methyl dopa, enalapril, captopril can be given, because they pass through breast milk, but still there are not many side effects. The clonidine and hydralazine can be used as second line drug. And what to be avoided? The big 5 A's. 5 A's. What are 5 A's? One is amiodarone, aldactone, anticoagulant, any statin or angiotensin inhibitors are ACE or ARB. The 6th A is avoid them. So you have to avoid these drugs during pregnancy. Then treatment of mild chronic hypertension during pregnancy. You know, when we were students, we thought the treatment of hypertension in pregnancy not necessary. Now the CHAP trial and the CHIP trial have proved mild hypertension also leads to better prognosis outcomes with no increase in risk of small for gestational age of birth weight. So we give, according to newer guidelines, even you can start the treatment at 140/90. That is the way forward. ACOG says in the earlier start the treatment before it is more than 160, 110. But the CHAP trial found the treatment led to 20% in pregnancy complications, such as preeclampsia and preterm birth before 35 weeks of gestation. Among the active group in the study, preeclampsia decreases from 29 to 23, and preterm birth decreased from 16 to 12 if you use the early treatment in 140/90. Now, I'll come to the last part of my talk, conclusion. The important question, the treatment-induced blood pressure reduction in pregnancy may be associated with decreased fetal growth. In pregnant women with mild to moderate hypertension, is the treatment with oral hypertensive medication associated with impaired fetal growth? Don't reduce below 110/70. Always preferable BP 120/80, because the more reduction can cause fetal hypoperfusion. Now, the recurrence, you must be always careful and get the history from the pregnant woman, whether they had previous eclampsia, pre-eclampsia, gestational hypertension, because the chance of recurrence in everywhere is high. 1 in 5, pre-eclampsia 14%. Whereas in the chronic hypertension, of course, not applicable. Gestational hypertension 9% or 6 to 12%. Now, very important point and important slide, which everybody must, watch this. See, once the delivery is over, you think everything is over. No. In a pregnant woman, if they have gestational hypertension or preeclampsia, these are the main hypertensive disorder pregnancy, where the risk of CVD and hypertension less than 10 years is 2+ and 3+ in gestational hypertension. Same way preeclampsia 2+ and 3+. But come to this important history, small for gestational age. Always ask the patient whether the delivery was small for gestational age or preterm delivery. If the history is given by the mother, the risk of CVD and hypertension is 3+ even even within 10 years. Whereas after 10 years, the CVD risk in the gestational hypertension is 1+ and preeclampsia is 2+. Whereas stroke, coronary heart disease, heart failure, you look at this small for age and preterm delivery is 3+, 3+, 3+. So what it means, in a patient who is delivered, always be careful when they come for checkup, ask for this history. And if this history is there, you must be more vigilant, follow up so that you can prevent problems. So key takeaways, hypertensive disorder pregnancy is one of the most intriguing yet unsolved problems associated with a long-term increased risk of cardiovascular disease. Screening and treatment of chronic hypertension, hypercholesterolemia, type 2 diabetes, obesity following pregnancy may delay or even prevent cardiovascular complications. Labetalol, hydralazine, and immediate release oral lipidopin are suitable treatment. Now, pregnancy offers a perfect opportunity to evaluate women with much earlier and instill cardiovascular prevention strategies early instead of waiting until midlife when women may have already developed precursors of disease. You must check pregnancy as viewed as a cardiometabolic stress test. But just like we do stress test, pregnancy may be viewed as a cardiometabolic stress test. And this pregnant woman, after delivery also, you can follow up properly to prevent complications. So now summarizing, preeclampsia, I told you, defective spiral artery remodeling. Defective spiral artery remodeling. There is a placental hypoperfusion because of the defective spiral artery. There's hypoperfusion, and this releases systemic vasoconstriction and endothelial dysfunction. And these diseases releases pro-inflammatory proteins into metal circulation, anti-angiogenic factors like SFLT, etc. And then this can cause problems in the liver, heart, blood vessels. So they may have all these things, hemolysis, low platelets, proteinuria, and they have problems. The right time for baby and mother, the curative treatment to consult and do. Thank you for your patient hearing. I'll be happy to answer questions. And I think I will finish up the questions and I go to the second speaker. That should be better, I think. What do you say, Sendil? Shall we complete these slides? Or we'll have the question and answer at the late after all the three speakers. Ananda Chokalingam?
We can have the questions, sir.
Anburajan? Okay, now I think more than 800 people are there. I will answer all questions in the chat box, whatever you have given. Now I will call the next speaker. Is the next speaker ready?
Yes, sir. I'm ready, sir. Kumaravel, sir.
Yeah, so I'll ask Kumaravel to give his talk, because after end of all the 4 talks, we can have some discussion and answer questions. Now, there is no need to introduce Kumaravel. He's one of the excellent endocrinologists, a very great academician, good communicator. So he's going to talk to us on pregnancy diabetes. We have talked about pregnancy hypertension in continuation with pregnancy diabetes by Kumaravel. Over to you, Kumaravel.
Thank you, sir. Is my slides visible, sir?
Visible.
Yeah, thank you, sir. And thank you, Dr. Muruganathan, sir, and IMA CGP for this wonderful opportunity. Sir, it was a wonderful talk, and it was always a pleasure hearing your talk. And the topic which I am going to discuss today is on diabetes and pregnancy. Murugan sir has spoken on diabetes and hypertension. I would talk on diabetes and pregnancy. So diabetes and pregnancy, it could be either pre-gestational diabetes or gestational diabetes. Pre-gestational diabetes basically precedes the diagnosis of pregnancy. What do you diagnose first? Whether you diagnose diabetes first or pregnancy first. If you diagnose pregnancy first and diabetes second, it becomes a gestation. If your diagnosis of diabetes precedes your gestational diagnosis, it becomes pre-gestation. So in this context, I would discuss about pre-gestational diabetes. A known diabetes patient is planning for pregnancy, what exactly has to be done. Next, we would discuss on gestational diabetes, the diagnosis, why you should be diagnosed, and when to diagnose, and how exactly it has to be diagnosed. And we will discuss about monitoring, because once it becomes hyperglycemia and pregnancy, whether it's a pre-gestation or gestation, your monitoring is going to be more or less similar, whether it's a maternal monitoring or fetal monitoring. Then I would try to focus on some treatment aspects of how exactly we should manage diabetes in pregnancy. So why is it very important? Pregnancy is a very, very critical time for tight blood sugar control. This is a very, very interesting data which looked at hemoglobin A1C and fetal malformation. When your HbA1c is less than 6, your fetal malformation was roughly around 9.3. While your HbA1c was somewhere between 6 to 7.2, your fetal malformation increased to 14.8. As your HbA1c increased to roughly, say, when your hemoglobin A1c was roughly around 8.5, your fetal malformation is 23%. So when you try to look this cutoff, your HbA1c less than 8.5, your malformation is 3.4. And when your hemoglobin A1c is more than 8.5, your fetal malformation is 22.4, and it increases exponentially as your hemoglobin A1c increases. So hyperglycemia in pregnancy is very, very detrimental to the fetus. Mild hyperglycemia can cause early growth delay. Moderate hyperglycemia might cause congenital malformations. Severe hyperglycemia can cause spontaneous abortions. I'm sure we would have seen in our routine clinical practice, you see a patient spontaneous abortion, check the blood sugar, which is 300, or your HbA1cs are 14 or 15. So this is not uncommon scenario what we see in our day-to-day clinical practice. So mild hyperglycemia is just a growth delay. Moderate leads to congenital malformation, which is commonly rectal malformation or respiratory lung malformation, or it could cause imperfect ANS, GI malformations. Severe hyperglycemia in pregnancy leads to spontaneous abortion. Now, having known about this tight glycemic control and having known about uncontrolled blood sugar leads to various complications, it is very, very important for we doctors to do pre-conception counseling to most of our diabetes patients. So we can have a type 1 diabetic or a type 2 diabetic. Initially, we were seeing lots of type 1 diabetics in young age. Now we do see type 2 diabetes in young age also because of your obesity, insulin resistance, and various metabolic complications. If the patient's on type 1, patient's already on insulin, so you just have to control the blood sugar, nothing much has to be done. But if the patient is type 2, who's already on various drugs, if it's a patient on metformin, patient could be on sitagliptin, patient could be on SGLT2 inhibitors, patient could be on sulfonylureas, any of these drugs, it is always preferable to change to insulin, control the blood sugar, achieve euglycemia, and maintain your hemoglobin A1c to 6.5. Of course, metformin could be safe in the first trimester because even in those patients with polycystic ovarian syndrome, we continue metformin up to 12 to 20 weeks because continuing metformin prevents your first trimester abortions. So if at all you want to continue your oral anti-diabetic medication, apart from metformin, no other drug as safety has been proved. So it is always preferable to change to insulin in all patients with pre-gestational diabetes. And of course, there are certain complications which could get aggravated in pregnancy. For example, diabetic retinopathy aggravates in pregnancy. Diabetic nephropathy aggravates in pregnancy. This is of vital importance in patients with type 1 diabetes. Patient has been diagnosed with diabetes at the age of 6 years. Patient becoming pregnant at the age of 26 years. It's a diabetes of 20 years duration. There's all probability these patients could have end organ damage like retinopathy and nephropathy. So they have to be screened earlier. If necessary, laser or any intervention has to be done. And of course, hyperglycemia can lead to neural tube effects. There have been data to support use of folic acid in preconception. Of course, you have data for both for and against, but it is always better to have a folic acid or iron or any nutritional micronutrient supplementation as a part of preconception counseling. So this is a known diabetic patient becoming pregnant. Now, what is GDM? GDM or gestational diabetes is nothing but carbohydrate intolerance of various degrees that begins or first time detected during pregnancy. So GDM will also include undiagnosed type 2 diabetes, which has been diagnosed in pregnancy, which you call as occult type 2 diabetes. The definition of GDM holds good irrespective of use of insulin or diet, whatever way you treat. It is not necessary a patient with blood sugar of 200 controlled with diet need not be a GDM. Still, it becomes a GDM. And the diagnosis of GDM also holds good irrespective of your perinatal outcomes, whether the patient is having obstetric outcome, any adverse maternal-fetal outcomes. So irrespective of the outcomes, it becomes a GDM. And again, your GDM definition per se is irrespective of future diabetes to the mother and fetus. So GDM by definition is first time diabetes diagnosed in pregnancy, irrespective of whatever treatment you take, irrespective of whatever outcome it happens, or irrespective of future risk of diabetes. As I said before, pre-gestational diabetes precedes the diagnosis of pregnancy. So it happens before that. Now, in diagnosis, why is it important to screen for gestational diabetes? As I said before, your maternal fetal complications are much higher with hyperglycemia. When you try to look at potential fetal complications, it can lead to macrosomia, it can cause birth trauma, it can cause prematurity syndromes, neonatal hypoglycemia, and of course, various electrolyte abnormalities starting from hypocalcemia, hypomagnesemia, you can have prolonged physiological jaundice, hyperbilirubinemia. Of course, it can lead to subsequent childhood and adolescent obesity also, as seen with babies born from gestational diabetic mothers. So now, what are the potential maternal complications? The chances of pregnancy-induced hypertension and preeclampsia is very high. Urinary tract infections are common in patients with diabetes and pregnancy. There's a more chance for cesarean section. There's a more chance for future diabetes in a mother. So it is very, very important for us to screen and diagnose because the potential adverse maternal and fetal outcomes are much higher. Another important thing which has been discussed with most of these patients with pregnancy and diabetes is that apart from mother, your hyperglycemia in pregnancy can cause fetal programming where it can cause long-term implications. So what is this fetal programming? So fetal programming is nothing but your metabolic factors in the intrauterine environment, which could be cholesterol, which could be blood glucose or whatever it is. And what commonly we say is these metabolic parameters like glucose can have a profound effect on your prenatal development. And this in turn leads to enhanced susceptibility to later chronic disease. How exactly does this happen? Gestational diabetes mellitus, there's maternal hyperglycemia. We know this maternal glucose traverses the placenta and reaches the fetus. So your fetus secretes more and more of fetal insulin in response to this fetal hyperglycemia. And we know this insulin is a growth factor, which in turn leads to neonatal fat, fetal insulin resistance, and enlargement of the pancreas. So both large for gestational age and average for gestational age infants from GDM mothers have increased fat compared to infants without GDM. And apart from that, your high fetal insulin levels influence the hunger centers, especially hypothalamus, which is involved in the energy balance. So because of the increased influence or increased metabolic priming of your hunger centers, it can lead to neonatal obesity and impaired glucose tolerance in the later stage. So whom and when to screen? Now we know there is a predominant maternal and fetal outcomes. So there are certain criteria like who has to be screened. So patients with high risk for GDM are those patients with marked obesity, history of GDM, leukosuria, or family history of diabetes. You should screen them as soon as feasible, whenever you catch them in pregnancy. And if it's negative, you should retest them between 24 and 8 weeks of gestation. And mothers with low risk status are those with age less than 25 years, normal weight, normal ethnic group, no history of abnormal glucose tolerance, no family history of diabetes. Average risk are those patients who belong in between to low and high risk of GDM. Now, whom to screen in Indian settings? Ethnically, Indians have a high risk for type 2 diabetes. Obesity and PCOS prevalence is increasing here. Metabolic syndrome is more. So universal screening is probably required in our setup. So every pregnant mother has to be screened for gestational diabetes. So next, how do you screen for these patients? You have various criteria starting from O'Sullivan and Mahan criteria, NDDG, Carpenter-Couston, WHO, DIPSI, IAD-PSG, ADA, and now we have ADA 23-24, which has more or less endorsed the same guidelines. So initially, most of this glucose tolerance test was based on 100 gram glucose. Now it is 75 gram glucose. That is number one. You have either one step or two step screening. One step is that you do a glucose challenge test and then do a glucose tolerance test. Now, what is the difference between glucose challenge test and glucose tolerance test? Glucose challenge test is basically, it is done whenever patient sees you in the clinic. It could be the afternoon time or it could be the evening time. A patient could have had a breakfast or had a lunch. You just give 50 gram of glucose and check your glucose after 1 hour. Anything more than 140, the probability of GDM is high, and these patients should undergo oral glucose tolerance test. When I say oral glucose tolerance test, it should be done in fasting with 75 gram of glucose. So this glucose challenge test is something like a screening tool, and this oral glucose tolerance something like a diagnostic tool of GDM. So which means you have to do it twice. So some criteria like say DIPSI criteria, they say you give just 75 gram glucose and do it after 2 hours. So what I would suggest is you can follow any of these criteria, whichever is comfortable for you, but stick to one criteria, be sure how it is done and be ready to interpret it. Don't keep on changing criteria or keep on jumping criteria. There is not major difference between numbers and all these are statistical overplay. So gestational diabetes mellitus, GDM guidelines, SACIA guidelines, that is the DIPSI guidelines is the one which is most commonly followed up in our setup. And I was one of the panel member in this DIPSI meeting experts, and that is one thing which is very commonly followed. So the practical approach, how do you screen? Now you can use either ADA criteria or DIPSI criteria. When do you screen? When it's a known diabetic patients or patients with a high risk of diabetes, especially polycystic ovarian syndrome, or those patients with obesity or family history of diabetes, these women should be screened even in prenatal before pregnancy. So you do a 2 hours 75 gram oral glucose tolerance test. If for some reason you have missed the space for screening prenatally in high risk individual, or if a patient is a low risk individual who has been diagnosed with pregnancy, universal screening is recommended in 6 to 8 weeks, which could be either two-step approach. As I said, you can do a glucose challenge test and oral glucose tolerance test. Or if the patient is coming to you with fasting, you can directly go with the oral glucose tolerance test. Hemoglobin A1C is useful in first trimester to diagnose occult or undiagnosed gestational diabetes mellitus or undiagnosed type 2 diabetes. If suppose your hemoglobin A1C is 8 in the first trimester, there's all probability this patient could have had diabetes even before patient is pregnant. Why is it very important? Because whenever you diagnose gestational diabetes in patients with mother and tell them you have a diabetes, the next thing they would ask is whether it affects the baby. Second, whether this will continue even after pregnancy. If your first trimester HbA1c is high, that's all probability this is going to continue even after pregnancy. If your first trimester HbA1c is normal, that's all probability your GDM could recover after your childbirth. So next to 6 to 8 weeks, 24 to 28 weeks is a universal screening. Again, you can go for single step or double step approach. After that, if it is negative, it is not necessary you have to screen regularly. At 32 weeks, you do a selective screening. What do you mean by selective screening? Rapid weight gain, and you have a polyhydramnios, or you have a fetal macrosomia, or fetal growth is disproportionate to the age of gestation. You can do a selective screening for these patients. So prenatal, whenever it's feasible, first trimester and second trimester, it has to be done. Third trimester is a selective screening for those patients with gestational diabetes. How do you screen? You can use either DIPSI criteria or ADA criteria. Stick on to any one criteria which you are familiar and which is easily feasible for you. So once when you have diagnosed gestational diabetes, what is the targets to be maintained in pregnancy? Your fasting blood glucose should be less than 90 milligram per deciliter. Your 1 hour plasma glucose should be less than 140, and 2 hour plasma glucose should be less than 120. Pregnancy is one area where you monitor 1 hour postprandial glucose. In all other routine clinical practice, you monitor for either 1.5 hours or 2 hours postprandial glucose. Pregnancy is one area where you monitor 1 hour postprandial glucose, because even a milder degree of hyperglycemia can enter your fetal circulation and can have an adverse fetal outcome. So you have to monitor 1 hour in pregnancy. And hemoglobin A1C has to be between 6 to 6.5. But of course, in pregnancy, after this first trimester, because of the change in RBC turnover, your HbA1c could be falsely high or low. So if feasible, you can go with fructosamine, which basically reflects your 2 weeks blood glucose control. So we know that we have diagnosed, now we know the targets. Now how do you manage? Medical nutrition therapy. So this depends on how much calorie you want to give. So if the patient is obese, which is more than 150 of the ideal body weight, you give calorie restriction of 12 kilocalories. The patient is an ideal body weight, it is 30 kilocalories per kilogram. If the patient is lean, you give 40 kilocalories per kilogram. And of course, your carbohydrate should be not more than 50%, and fats and proteins should be 30% and 25% respectively. And adjustment of diet should be based on the weight gain in pregnancy and the ketonuria what the patient has. Exercise, definitely patient can do exercise, and exercise is always preferable to advise in association with obstetrician, because they can have other, say they can have a cervical incompetence, or they can have other comorbidities or obstetrical complication which can inhibit the exercise. So exercise is always advised in association with obstetrician, but it is always preferable to have exercise at least 3 times a week, and each session should be at least 45-minute session. It is advisable who are doing exercise should continue the same. Patients are already doing exercise, they should continue the same. And others to do a walking or gentle upper body exercise is recommended in pregnancy. Drug therapy, next to lifestyle, drug therapy, until today, insulin therapy is the cornerstone of management of diabetes in pregnancy if diet alone is inadequate. And human insulin or analogs should be used, and SMBG, which is nothing but self-monitoring of blood glucose, should guide the doses and timing of insulin regimen. So the insulin requirement varies in various trimesters. In first trimester, the insulin requirement is usually 0.7 into ideal body weight. Second trimester is roughly around 0.8, because as pregnancy advances, because of the effect of HCG and progesterone, there is more and more of insulin resistance, so the insulin requirement is high. Third trimester, it is roughly around 0.9 per kilogram. So in type 1 diabetes, the insulin requirement increases by 10%. In type 2 diabetes, the insulin requirement usually increases by 33%. Pre-gestationally, type 1 diabetes requiring insulin of 30 units, in pregnancy, it becomes 33 units. In type 2, pre-pregnancy requiring insulin of 30 units, it becomes 40 units in pregnancy because of the increased insulin resistance state of your pregnancy. Once you have decided on insulin, what insulin to choose, you can choose various regimens. The best thing would be to have a 4 times daily regimen, what you call as a basal bolus therapy. So the source of glucose for your body is the endogenous glucose, which is produced from your liver and the kidneys, and exogenous glucose, which is predominantly based on the diet what you take. So normally you eat 3 times. So you have a 3-prandial insulin which is secreted, and there's a basal insulin which is secreted, which takes care of your hepatic glucose output. So in pregnancy, it is always better to have a long-acting insulin and 3-prandial short-acting insulin, so which is very easy for us to control your blood sugar in pregnancy. If suppose patient is finding it difficult to take 4 times insulin, you can give 3 times insulin, that is short-acting for your breakfast, short-acting for your lunch, and night you can give a pre-mixed insulin, where the short-acting component will take care of your dinner and the long-acting component will take care of your whole night prandial basal cover. If still it is not feasible, you can give twice daily insulin, which is pre-mixed short-acting component for the breakfast and a long-acting component which will take care of your lunch. And again, evening you can give another pre-mix which will take care of your dinner and the whole night. But remember, when the number of injection comes down, your control becomes poor. When the number of injection increases, your control is good, but your compliance becomes poor, because the patients generally find it difficult to take insulin 4 times a day. But it is our responsibility to convince them to take insulin 4 times a day for better glycemic control and for better maternal-fetal outcome. So OHAs in pregnancy, OHAs were considered an absolute contraindication pregnancy until recently. Though OHAs have made a comeback, now I'm sure most of the UK trained people and most of the guidelines in UK, they start using OHAs, especially metformin has been very commonly used. And even current medical textbook recommends the use of glyburide, which is glibenclamide in pregnancy. But we really don't know the safety of these things. I would not say these are harmful, but safety of insulin has been proven, but safety of these things has not been proven. But of course, you have various anecdotal reports and some case reports are available. But if you are able to convince insulin is the best in pregnancy for a better maternal and fetal outcomes. So once when you have started them on insulin, how do you monitor? So maternal surveillance, you go for self-monitoring of blood glucose, you look for urine ketones, you look for blood pressure and urine protein has to be monitored. Hemoglobin A1C in first trimester and further trimesters, you can go for fructosamine test. Continuous monitoring is a great tool, especially in pregnancy nowadays. I will tell you how exactly it would be useful. And monitor for microvascular complication, especially in those patients with pre-gestational diabetes. And gestational diabetes, microvascular may not be a major issue. So in pre-gestational diabetes, you have to monitor. Type 1 or type 2 diabetes, intensive monitoring should start from day 1. Gestational diabetes, monitoring should start once when you diagnose. 4 times a day, glucometer reading is ideal. And if the target glucose is achieved, you can monitor twice in a week by around second trimester, end of second trimester. Then it is thrice in a week after 32 weeks because your fetal macrosomia is high as the number of weeks advances. Fetal monitoring, baseline ultrasound should be done to assess the fetal size. At 18 to 22 weeks, you do a major malformation scanning fetal echocardiogram. From 26 weeks onwards, you try to monitor for fetal growth and recover volume. Third trimester, frequent ultrasound for accelerated growth and look for abdominal and head circumference ratios, which in turn tries to give you the early fetal macrosomia could be assessed based on these things. Now, with this overview of what exactly has to be done, I will take on to some case scenarios. And of course, your delivery of all these things should be based on the obstetric indication. And since the patient has a GDM, it is not necessary you have to deliver the baby earlier. So you try to push on as early as possible. At least 38 weeks is ideal to have a better fetal growth. So I have a very interesting case, 25-year-old female. This is something for a better understanding of what we have discussed before. So it is a preemie, 26 weeks pregnant. Patient is obese, no family history or no polycystic ovarian syndrome. This patient underwent oral glucose tolerances. You can see the fasting is 100. 1 hour post-prandial glucose is 198, 2 hours 160. You can look at it, the fasting value more than 92 and 1 hour is more than 180 and 2 hours more than 153. Any two values above this is abnormal. So this patient, as per diagnosis, it is a gestational diabetes. So initially, you may not start them on insulin immediately. So I would put this patient on diet, monitor the blood glucose for 3 days. Because this is done with oral glucose challenge. This may not be the same scenario in those patients with a normal diet. With normal diet, I monitor the fasting plasma glucose. I monitor 1 hour post-breakfast, 1 hour post-lunch, and 1 hour post-dinner. My target has to be less than 140. You see, your fasting plasma glucose is less than 100, which is perfectly fine. Breakfast should be less than 140. Only one day it is 156. Lunch, again, it should be less than 140. One day only 152. Dinner, again, it should be less than 140. Only one day 142, which is very easy to get it dealt with diet alone. So this patient may not require insulin at this circumstance, but you have to monitor them frequently. And if necessary, insulin has to be started. I'll give you another case scenario, something similar to before. This is a 22-year-old female, second gravida, again 24 weeks pregnant, no family history of PCOS or no history of GDM. Patient is a normal weight. You can see the oral glucose tolerance 104, 186 and 184. Again, these fits in with the criteria of gestational diabetes. Something to a similar case, we have put this patient on diet. Now I monitor this patient blood glucose value after 3 days. Thus, in pregnancy, you cannot afford to wait for 2 weeks or 2 months because your pregnancy progresses very fast. Your fasting glucose is 78, 88, and less than 100. I'm happy with it. Your postprandial blood sugar is consistently more than 140. Your post-lunch is more or less normal. Your post-dinner is consistently more than 140. Now this patient would require a prandial cover for your breakfast and prandial cover for your dinner. No prandial cover is required for your lunch. Fasting is normal, so no basal insulin also will be required. So I start this patient with Actrapid 4 units before breakfast and 4 units before dinner. So that alone will be more than enough. Now I'll give you another case scenario, which is a 36-year-old female, obese, second gravida, 8 weeks of pregnancy. So this patient gives a history of GDM where this patient was treated with 55 units of insulin during the previous pregnancy. So has a family history of diabetes, very high risk patient. So this patient fasting plasma glucose is 136. So any plasma fasting sugar more than 126 qualifies for the patients of diabetes mellitus. So GTT may not be required for this patient. So you just do a hemoglobin A1C, which is 8.5. So since your HbA1c in first trimester is more than 6.5%, this is all probability it's a pre-gestational diabetes, which is diagnosed during pregnancy. So this patient will most probably continue to require insulin, and after delivery also, she would continue to have diabetes. So treatment, this patient would be started with short-acting insulin in the morning, afternoon, and pre-mixed insulin in the night. Now monitoring, we have seen monitoring with glucose meter, but in pregnancy, it is very difficult for us to do a CGM every time. Glucometer reading every time. So this is something called continuous glucose monitoring, like you have Holter monitoring for BP monitoring. So this is freestyle Libre. This is just a coin shaped thing. You have a reader, and now this comes with your Bluetooth enabled in your phone itself, whether you have iPhone or Android phone. You can just download this app, just show it, you will be able to see the reading. So this patient who is already on Actrapid 440 and Mixtag 004 was put on continuous glucose monitoring, and this can be on for 14 days, and it measures your blood sugar every 5 minutes, whether you are sleeping or taking bath or whether sitting ideally. So it gives you an overall picture of your blood glucose. So this is how your reading happens. So this patient, you can see postprandial, there's a peak, and there's a pre-lunch, there's a dip, hypoglycemia. Again, post-lunch, there's a peak. Post-dinner, there's a peak. The same pattern continues for 3 days, whatever we have seen. So everywhere it is high. And this patient is already on Actrapid 440 and Mixad 004. Now, if I increase the insulin because of this postprandial peak, your preprandial hypoglycemia is going to worsen. So if I decrease the insulin because of a preprandial hypoglycemia, my postprandial peak is going to increase. So this is the scenario where human analogs, they scores better, because human analog insulin, your onset of action is faster than your regular insulin, and the duration of action is also less. So what we did is, instead of Actrapid, we made this insulin Aspart insulin, which is NovaRapid, 4 units in the morning, 4 units in the night. And night, instead of Mixad, we have made it Novamix 30, which is a pre-mixed Aspart analog insulin. You can see the difference. Just changing the insulin alone, we are not changing any dose. You can see the blood sugar is perfectly under control. No postprandial peaks, no preprandial lows, and your average blood sugar, you can see, is roughly around 110 to 128, where you can have a best maternal fetal outcome in these patients. So the charm of treating patient is controlling your hyperglycemia. Treating your blood sugar without hypoglycemia is a challenge in a day-to-day clinical practice. So you can see the overall blood sugar control. Your estimated HbA1c is 5.8. No blood sugar is more than 140, and everything is well under control. So this is my last patient, a 32-year-old female, type 1 diabetes for 9 years. She's euthyroid, no retinopathy and nephropathy. Now she's 6 weeks pregnant. And she's on Insulatard, which is nothing but a long-acting or intermediate-acting insulin, 30 in the morning, 20 in the night. Short-acting insulin, 32, 12, and 35. She presents with recurrent hypoglycemia mostly at the night, but still a HbA1c is 1.6, which means her blood sugar has to be better under control. HbA1c denotes the patient's having hyperglycemia, and recurrent hypoglycemia is a challenge for us to increase or decrease the dose. So this patient, again, we did a continuous glucose monitoring. You can see this patient has a hyperglycemia, and this patient also has a nocturnal hypoglycemia. Now, what happens with this Insulatard and other Insulatard or Lantus or any insulin is that you are giving a basal insulin for 24 hours. So if you are giving, say, 24 units of Lantus at the night, The Lantus, which is released every hour, is roughly around 1 unit per hour. Similarly, when you are giving 45 units of insulatard per day, the insulatard released per hour is roughly around 2 units of insulatard. Now, I need a certain time where your long-acting insulin has to be released. I need a certain time where your long-acting insulin has to be stopped. I need a certain time where your long-acting insulin has to be increased. So this cannot be done with a routine existing insulin. So that is the scenario where you require an insulin pump. So insulin pump, the advantage is that it delivers a short-acting insulin as a short-term pulse and also as a long-term. So your bolus is depending on the food, you can give 25, 10 or 18. Your basal can be arranged. Our patient had a nocturnal hypoglycemia. So night I needed a lower insulin dose. So I can set midnight 1 a.m. to 4 a.m. to 0.4 units per hour. Morning, this patient has hyperglycemia. I can set from 4 to 9 is 1.5 units. 9 to 1, again, you can reduce to 0.2 units. You can have various basal regimens adjusted. You can even have 20 basal regimens in a day. So this is a real advantage of the pump to have a better blood sugar control. So this patient, you can see the various basal regimens depending on what has to be adjusted, and bolus depending on the insulin dose patient what you have 3 bolus regimen and varying basal regimens. You can have a stepwise basal regimen which is feasible. So after changing these various basal regimens, you can see the blood sugar control of this patient, which is perfectly under control. And ultimately, this patient delivered a male baby, full-term normal delivery, and the birth weight was 2.9 kilograms. And this is a pre-gestational type 1 diabetes who had a normal delivery. And of course, it is a team care. And it is the responsibility of the patient, gynecologist, and the endocrinologist who has taken care. And we published the first case report of diabetes pregnancy managed by insulin pump. And now this insulin pump has been very widely used in many of our pregnant patients. Continuous glucose monitoring has been used, and the technologies have really aided us in controlling their diabetes in pregnancy and to have a better maternal fetal outcome. So as I said, delivery, the timing and mode, when antepartum testing suggests fetal compromise, delivery must be considered early. If a patient reaches 38 weeks of gestation, whenever there's a significant risk of intrauterine demise because of poor control, you do an early delivery. Larger for gestational age, induction of labor could be planned, and macrosomia, you can do elective LSCS. But preferably manage expectantly till 40 weeks, and LSCS is predominantly for obstetric indication, not because the patient is having GDM. Once when the baby is born, immediate postpartum also has to be monitored. Insulin recommends disappears in GDM, changes to pre-pregnancy levels in pre-gestational diabetes. And diabetes will disappear in 90% of GDM cases, but they have to monitor because 50% would reappear within first 3 years. Continue monitoring mother and fetus for at least 2 days as indicated. The risk of subsequent diabetes is about 30% in the mother. So you screen all gestational diabetes mother 6 weeks postpartum, 6 months postpartum, and then once in 3 years. Especially when there's marked hyperglycemia during pregnancy, and especially hyperglycemia persists after pregnancy, early onset GDM, obesity, patients with prior history of IFG, IGT, or acanthosis or polycystic ovarian syndrome, the probability or chance of recurrence of GDM is also very high, and which is roughly around 50%. Just to conclude, hyperglycemia and pregnancy is very common. Achieve euglycemia before conception. Universal and first trimester screening for gestational diabetes. Strict maternal and fetal monitoring is important in pregnancy. Postpartum testing for diabetes mellitus is essential, and it has to be told to every gestational diabetes mother. And thank you. Thank you so much for your attention.
Thank you. Hello. Kumarvel, I
Yes,
think
sir.
it was an excellent talk. I think you have to go for your work and clinic. So I'll finish your topic now. I'll ask you a few questions, then we'll ask the next speaker, Vidya, to come. Okay.
Yes, sir.
Because I want you. I know you are a very busy person.
Not an issue.
Kumarvel, it was an excellent talk. Now, tell me, you have given so many protocols for a practitioner. Simply, what would be the best way of screening? You said universal screening, challenging, and also doing routine tests. Now the government of Tamil Nadu also has accepted universal screening. So just give me simple way, whether you give 50 grams and then do the 1 hour test, or you do challenging test? What is the best way?
So there are two best ways which could be done. One way is that whenever patient comes to you, you give 75 gram glucose and get a blood glucose after 2 hours. If it is more than 140, diagnose them as GDM then and there. So this is one easiest thing.
Okay.
Second thing, most of the institutes, they do a better validated thing where they give 50 gram glucose whenever patient sees you, and 1 hour more than 140, they suggest oral glucose tolerance test. So these are the two things which is recommended, and you can do whichever is feasible for you.
Okay. So the advantage of 50 grams is no need of fasting, nothing. Just come anytime, even if they have finished their lunch, give 50 grams and then check the blood pressure, blood sugar after 1 hour. If it is more than 140, you suspect this patient may have gestational. So you do the complete glucose tolerance test, correct?
Yes, sir.
Okay. Number two, the insulin part, you have given so many case discussion. Just give a drive home message. What should be the insulin? How do you calculate insulin in a patient where you will avoid nocturnal hypoglycemia as well as hyperglycemia?
Yeah, so usually the insulin which is recommended is, though analogs has been approved in pregnancy, we commonly use human insulins in pregnancy. So short-acting insulin is preferred because the postprandial hyperglycemia is very high. So what I would suggest is use short-acting insulin for your breakfast, short-acting insulin for your lunch, short-acting insulin for your night. So you have 3 short-acting insulin for your prandial cover, and use a basal insulin, which could be a Lantus or insulatard at the night. So which will take care of your fasting glucose. As I showed the glycemic chart, you monitor blood sugar 4 times a day for 3 days. Based on that, you can increase, whenever your glucose is increasing, you can increase the insulin or decrease the insulin. So it's very easy to titrate. So 3 short-acting insulin before food and 1 long-acting insulin at bedtime. Second, monitor blood glucose 4 times a day, fasting, and 3 postprandial blood glucose. Number 3, titrate the insulin based on your blood glucose value. This is the easiest thing which could be followed. It is very difficult to suggest how much insulin which each patient would require. So generally what I would suggest is, if your blood sugars are very high, say 200, 300, you can start roughly around 24 units per day in divided doses. If suppose your blood sugar is less than 200, it's just 140 or 150, because that's what most of the GDM, they come to us. They come to us with 160, 170. You start with 12 units per day, which is 3 short-acting 4 units, and say 6 units of basal insulin, and then up titrate or down titrate. Go slow, because once when the patient experiences hypoglycemia, they are not going to follow up with you. So always educate about hypoglycemia and go slow.
See, one practical problem, Kubravel, what you say theoretically, logically correct. Will you ask every patient to do 4 times blood sugar and all that? Is it practical?
So practically, there are 2 ways of looking at it, sir. Pregnancy is one time where whatever we say, the patient follows it, sir. Okay. If it's a non-pregnant, 4 times a day is definitely not possible. In pregnancy, most of the patient, they do it. Generally, what we do is, after this, we see 4 times, 3 days, then you see whichever sugar is high, then fix it. They are going to do it only 2 times a week, not more than that. If suppose it's not feasible, we tell them to do at least 2 times fasting and postprandial sugar, and based on that, we titrate.
And what about continuous glucose monitoring? Based on that, do you suggest some treatment for pregnant women?
So continuous glucose monitoring is a wonderful tool, sir, but the only thing is the cost factor. Because the continuous glucose monitoring would cost roughly around 5,500, which could be worn for 14 days. So if the patient is affordable, it is a single prick which could be done for 14 days.
Correct.
And it gives a wonderful message we can very easily control.
Yeah, that's why I just want to say. And one more question. You talked about pregnant women insulin. What about perioperative, preoperative, and postoperative in cesareans?
So whenever you're planning for cesareans, it's a similar match like any other surgical intervention. Usually what we do is, before patient is your plan for cesarean section, whatever insulin dose we reduce by 50%. Depending on the timing when it is planned, you reduce the insulin dose by 50%. And if the patient's in an NP1, you just give them, we always suggest them to give dextrose for those patients. Generally, we say any preoperative diabetic patient, don't give dextrose, don't give anything. Because I think the nutrition is required for mother as well as for the fetus. You cannot totally starve them. We tell them you give a dextrose infusion on one arm and give an insulin infusion on another arm and control the blood sugar. And once when the intraoperative also, it's the same thing. Anesthetists, they do a wonderful job. They take care, no burden for us. Post-operative, if it's a GDM, your insulin requirement totally disappears. If it's a pre-gestational diabetes, insulin requirement reduces by at least 30%.
Okay, because that is a caution, because many people have a problem perioperatively how to do. And sometimes suddenly they take for emergency cesarean. So you will have no plans also. A gestational diabetic patient suddenly develops some obstetrical complication, they may be taken to theater. So there also, you must be vigilant, as you said, insulin on one side, dextrose on side, anesthetists can manage, but still that is an important thing. Now, the last question, pregnant women normally have, not normally, many people have sleep apnea. The sleep apnea can produce nocturnal hyperglycemia. So this is one of the problems with pregnancy. So any take on that?
It's definitely possible, sir, because sleep apnea, what happens because of hypoxia and other things, you have more and more of counter-regulatory hormones which is secreted. That is one reason why there is more of nocturnal hyperglycemia. And sleep apnea has been a major challenge nowadays. And mostly it has been ignored previously, but these patients ideally should undergo sleep study and do a BiPAP or CPAP thing has to be done for these patients. We suspect them in those patients where blood sugar is totally uncontrolled or fluctuating. In spite of whatever devices you use, you're finding it difficult to control. In such scenario, we tell them to do all these things also, sir.
Okay. Is nocturnal hyperglycemia dangerous or the regular hyperglycemia dangerous?
All hyperglycemias are dangerous in pregnancies. As far as pregnancy is concerned, any blood glucose more than 140 is going to enter your fetal circulation.
Okay, fine. Now, the last question. Your one drive-home message for all our members.
Screen all pregnant patients for diabetes. So that is one thing which has to be definitely done. Because we see many patients who diagnosed at second trimester, though they have been seeing gynecologists many a times. So any pregnant patient screen for diabetes, any obese patient, PCOD patients planning for pregnancy, again screen for diabetes.
Okay, so screening and proper follow-up and healthy lifestyle is a very important thing for controlling pregnancy or controlling any NCDs. Thank you so much.
Thank you, sir. Thanks for opportunity, sir. Thank you, sir.
It was an excellent talk and a very crisp and simple talk. Now I'll request the other speaker, Dr. Vidya. Are you ready, Vidya?
Yes, sir. I'm here.
Yes. So Dr. Vidya needs no introduction. She's also one of the famous endocrinologists from Coimbatore. She's going to talk to us on diabetes and mainly musculoskeletal. And people who are diabetes, they have a lot of these problems of sarcopenia and muscle ache, things like that. And most of them also, they take statins at their age. So these all combined giving a lot of problems about musculoskeletal. Now Vidya will enlighten us on these challenging problems. Over to you, Vidya. Please go ahead. You can share your slides, yes. Go ahead, Vidya.
Yeah. Sir, is it visible, sir?
Yeah, it's visible. Yes.
Yeah. Good evening, everyone. Thank you, sir, for inviting me to give a talk on this topic that we don't usually discuss much upon. It's musculoskeletal manifestations of diabetes. The reason I picked up this topic is that it's a very under-recognized complication of diabetes. Though it's not as serious as micro or macrovascular complication, musculoskeletal deformities or any kind of these disorders can lead to pain, deformity, ulceration, loss of function, or independence. Loss of muscle strength or deformity could predispose a diabetic patient to falls, and falls could lead to fractures, to greater disability, loss of work, and financial burden. Recognizing these disorders is very important, and prompt management would prevent all of these above problems in our patient. So the common bone and joint pathologies that I'm going to be discussing today is fibroproliferative disorders of the soft tissue, frozen shoulder, dupuytren's contracture, carpal tunnel syndrome. Also disorders of the joints such as Charcot's gout and osteoarthritis, disorders of the bone, such as the diffuse idiopathic skeletal hyperostosis, osteoporosis and fractures, and CKD. Disorders of the muscles, such as sarcopenia, sarcopenic obesity, and I'm just going to touch upon motor neuropathy and diabetic myonecrosis. It's very difficult to go through all these conditions in great detail. It would be beyond the scope of this next 30 minutes of my presentation. So I'll be giving a brief overview of how these disorders present and what is the usual mode of management for these patients. So the first one is the chiroarthropathy. This is flexion contraction of the proximal interphalangeal joints or the metacarpophalangeal joints. Fifth, proximal interphalangeal joint is the first to get affected. Wrist, elbow, ankle, cervical spine could also be affected, and there are reports of reduced lung volume in severe cases. The prevalence has been reported to be as high as 25 to 75% in type 2 diabetic patients and up to 9 to 66% in type 1 diabetic patients. Limited joint mobility is one of the earliest complications of diabetes, and they usually present with the inability to hold cups or hold on to the rails of the stair because of the flexion contractions. And how do we detect? By simple bedside tests, such as the prayer sign, where you ask them to oppose their hands together, and we could see that they won't be able to oppose the palmar surface together because of the flexion contraction. Another way to detect is ask them to put their hand on the surface of the table, and you can see a clear gap between the table and their palm because of the contraction of the proximal interphalangeal joints. So why is it important to recognize and pick up these features is that there's a strong association with macrovascular complications in type 2 diabetes. The mechanism of why this happens could be because of altered mucopolysaccharide distribution, distribution of elastin, collagen, and reduced vascular lumen as well. Often these patients are either missed or they present quite late with disability. The treatment would be physiotherapy or steroid injection in order to relieve these contractions. Frozen shoulder, this we're very well aware of. Many times our patients, even in the pre-diabetic phase, present to us with painful shoulder, inability to abduct the shoulder. The prevalence is as high as 19% in the diabetics, while in the non-diabetic, the prevalence is only about 2 to 3%. In the diabetics, it can be bilateral disease or it could be unilateral. The risk factors being older age, longer duration of diabetes, previous myocardial infarction, retinopathy, and peripheral neuropathy. There are 3 phases to frozen shoulder that we should recognize. The painful freezing state is when the patients usually present to us with inability to, dry the clothes onto the robe or inability to comb the hair. Adhesive phase is the frozen phase where it's not really painful, but they will not be able to move their shoulder much. Resolution phase can take up to 2 years. It's also called as the thawing phase, where it can take up to 2 years for this frozen shoulder to get better. And this could be a recurring phenomenon where it gets better and then the patient develops a frozen shoulder on the other side or on the same side. And this could be a continuous process. The treatment is very good glycemic control, physiotherapy, intra-articular steroids for short-term relief, arthroscopic release. Most often these patients, when they go into a severe adhesive phase, they would need manipulation under anesthesia. Dupuytren's contraction, there's a flexion contraction of the ring and the little finger. 26% of our diabetics could have this when we look for these conditions. Risk factors being older the age, male, smoking, alcohol, manual labor, diabetes, and the longer the duration of the disease, the higher risk of developing Dupuytren's contraction. It is associated with macroalbuminuria in patients with type 2 diabetes. Trigger finger is because of the thickening of the synovial sheath over the tendon. They often present with clicking sensation when moving the finger. The lifetime risk in diabetics is about 10%. Treatment is usually steroid injection, but in diabetics, there's usually a poor response. There's a higher prevalence in type 1 diabetics, and more digits are affected in diabetics, and the need for surgery is more. And also the recurrence rate is high in our group of patients. Carpal tunnel syndrome is a compressive neuropathy affecting the median nerve. This could be because of the tenosynovial fibrosis, increased fibroblast, tumor growth factor being mediated type 3 collagen deposition. And these patients might need nerve conduction study to look for median nerve paresthesia. The treatment is local steroid injection, but if it is severe, these patients will need surgical release. Charcot's joint, a very, very important neuromuscular disorder of diabetes that could go undiagnosed or misdiagnosed if you do not have experience or if you do not have a low threshold to suspect the patient could have Charcot's joint. It's a destructive joint disorder leading to dislocation and fracture of foot and ankle bones. They can present as acute localized inflammation in a patient with diabetic neuropathy who has undergone very trivial trauma that the patient may not even remember. And because the patient has got peripheral neuropathy due to repeated microfractures, microtrauma, this leads to, over a period of time, to deformity. It is not very common, but where I used to work and where I used to train in UK and do a lot of foot clinics, clinics dedicated to patients with diabetic foot ulcer or problems with their feet, we used to see quite a few Charcot's joint, which need to be managed quite carefully. Otherwise, it will lead on to deformity and ulceration. 63% will develop foot ulcer because of the joint deformity, but often these Charcot's joints are misdiagnosed as cellulitis, osteomyelitis, or deep vein thrombosis. Sometimes Charcot's joint and osteomyelitis can coexist. Sometimes when we do surgeries like wound debridement or amputation for small joints because of osteomyelitis, that could in turn trigger a Charcot's arthropathy. The treatment is offloading the joint with appropriate footwear. Bisphosphonates could sometimes help, but eventually, if the patient has gone past the acute inflammation stage and the deformity has set in, we need to refer them to an orthopedic surgeon with special interest in feet who would be able to do corrective surgeries so as to prevent foot ulcers. So the mechanism is, there is in diabetic patients where there is hyperglycemia, there is increase in oxidative stress and advanced glycation and products and inflammation, leading on to vascular dysfunction and immune dysfunction. And because there is persistent infection from ulcers that fail to heal because of the deformity, this could lead to amputation or sometimes limb salvage surgeries. In patients with Charcot's neuroarthropathy, there is loss of protective sensation and repetitive microtrauma that goes undetected, leading on to fractures. And there's also localized osteopenia in these patients, leading on to deformity, again ulcers, and leading on to loss of limb. Gout is another condition that we are very well aware of. The prevalence is about 22% in diabetics. Risk factors being male, gender, renal impairment, use of diuretics, obesity, hypertension, ischemic heart disease. Apparently, seafood, meat, and alcohol can also trigger gout. Most often affects the metatarsophalangeal joints, could also affect the midfoot and ankle. They present as an acute painful foot, and we will have to think of the differential diagnosis as cellulitis, underlying abscess, but also gout. Management is SGLT2 inhibitors seem to help. Urate lowering therapy, painkillers in the acute phase. Losartan and fibrates seem to help reduce the urate levels, but we should be avoiding diuretics in these group of patients. Or once you started a patient on a combination of diuretic with an ARB for hypertension, and the patient presents with painful foot, then we should have an element of suspicion that it could be gout. Osteoarthritis, diabetes is an independent risk factor for osteoarthritis after adjusting for BMI. In obese women, there is increased risk despite adjusting for age and joint asymmetry. Chondrocytes express glucose transporters, and hence glucose seems to have both direct and indirect effect on the cartilage. There is higher risk of prosthetic infection, postoperative activity limitation, and the need for early revision in diabetic patients. So we cannot attribute all osteoarthritis to just being overweight or aging. Diabetes itself seems to have an association with osteoarthritis due to the mechanisms that I have just mentioned. DISH is not very common. I've come across one patient with this diffuse idiopathic skeletal hyperostosis, probably because the patients are asymptomatic and these are picked up instantly on x-rays. The prevalence apparently is 15% in women and 24% in men over 50 years of age. There is mainly ossification of the anterior longitudinal ligament. The other risk factors apart from diabetes or obesity, dyslipidemia, hyperuricemia. There is increase in insulin, IGF-1 and growth hormone in the initial phases leads to hyperostosis. And increase in osteoblast activation due to platelet-derived growth factor and TGF-beta-1 activation in diabetes. So what we usually find is as if the there's a candleback's appearance where the calcification of the ossification of the anterior longitudinal ligament gives an appearance as if the candle is melting off. The pictorial representation is on the left. Osteoporosis, the next two topics are the most important topics that I want to discuss, osteoporosis and sarcopenia, sarcopenic obesity. The mechanism of osteoporosis, especially in our diabetic patient, is that there is chronic inflammation, increase in the interleukins and TNF-alpha, increase in reactive oxidative stress, and advanced glycation end products. These all interrupt the bone formation cycle and the bone destruction cycle. So they increase the OPG, which is kind of an osteoclast mimic. There is increase in rank L, increase in PPAR gamma, leading on to the mesenchymal stromal cells proliferating into osteoclasts instead of osteoblasts. Similarly, the hematopoietic stem cells, when they all differentiate, they're supposed to differentiate and form more of osteoblasts. But because of all this inflammation and all the pathways for bone formation being altered, there is dysfunction leading on to increase in osteoclast formation instead of osteoblasts. This leads to decrease in bone formation and increase in bone resorption. But the mechanism is not that very straightforward because there is increase in insulin resistance and obesity as well, which leads to decrease in blood supply to the cortical bone. So what we find is cortical porosity in type 2 diabetic patients, and the glycosylation of collagen is altered, and there is altered collagen properties and mineralization. So there is an increase in fracture risk, low bone turnover, altered collagen properties and mineralization. All these leads to osteoporotic fractures in our diabetic patients. But ironically, when we do a bone density, the DEXA can be misleading because the bone mineral density can be either normal or it could be increased in type 2 diabetic patients. The fracture risk assessment tool that we use for patients to help physicians guide us to prescribe drugs to prevent or treat osteoporosis can be misleading. So we can Google for fracture assessment tool, and it will take us to Sheffield website where you put in a lot of parameters, including the age, height, weight, if the patient is a smoker, uses alcohol, is there use of steroid, as the patient got secondary osteoporosis. But type 2 diabetes is not in this list of secondary osteoporosis. So the FRAX tool kind of underestimates the risk of fracture in our type 2 diabetic patients. The fracture risk is about 1.2 to 1.4. the odds ratio at hip, forearm, and foot. But it's very uncertain if the fracture risk is actually increased at the vertebra. Perhaps qualitative CT or trabecular bone score might be useful marker to identify osteoporosis in diabetic patients because the bone mineral density could be normal or high despite an increased risk. What we shouldn't be doing is avoid, putting on drugs like pioglitazone that can affect the bone quality, or predisposing a patient to falls like, recurrent hypoglycemia. As I said, musculoskeletal deformities in the foot that can predispose a patient to falls. So falls prevention is one of the major things that we should be looking into in our elderly, frail, elderly type 2 diabetic patients who could have osteoporosis in either because they are a natural process of aging, on top of that menopause, and then now type 2 diabetes. Standard screening of high-risk patient is what is recommended despite the bone mineral density not being very useful. If it shows osteoporosis, we should start treating our patients. And again, preventing hypoglycemia, we should put patients on appropriate medications and not control their blood sugars very tight if they are vulnerable to falls, especially in the frail elderly patients. So pioglitazone, how does it cause osteoporosis? Is there activation of PPAR gamma that I have explained before. So there's increase in adipocyte, which leads to increase in adipocyte deposition in the bone. There is decrease in leptin and increase in osteoclastic activity. And again, indirect action through aromatase activity and decrease in estrogen production in the adipocytes. And all these put together, pioglitazone, because of the inherent property of PPAR gamma activation, again, the mesenchymal stem cells get differentiated into osteoclasts rather than osteoblasts, leading on to osteoporosis. When we talk about obesity, there's often a common misconception that obesity is protective for fracture. Obesity could itself be misleading in interpreting bone density because of excess abdominal adiposity. The DEXA scan could show that the patient, despite being osteoporosis, the T-score could be better or even normal. But obese patients are at increased risk of falls. It's just that they do not fall forward. They tend to fall backward because they're not able to balance. Hence, there's less risk of hip fractures because the fat pad around the hip helps them from getting fracture of the hip. But because they have the tendency to fall backward or they have the tendency to twist and fall, they are at increased risk of ankle fractures. And again, bone mineral density may be normal because of the abdominal adiposity obscuring the view. Sarcopenia, sarcopenic obesity is, we've been discussing about this over the past decade, but lately there are several guidelines that have come up with some idea about how we should start looking or screening for sarcopenia or sarcopenic obesity in our patients. Start off with the definition of sarcopenic obesity is a clinical and functional condition characterized by the coexistence of obesity, characterized by excess fat mass, and sarcopenia, which is defined as low skeletal mass, strength, and function. You should have at least two of these three: low skeletal mass, muscle strength, and function. You should have at least two of these three. The etiology of sarcopenia is multifactorial, and the prevalence increases with age. Primary sarcopenia per se happens in the elderly, but there are other reasons for secondary sarcopenia, and diabetes increases the risk of sarcopenia by 2.3-fold. Obesity and aging seem to have a kind of similar effect on the muscle. The pathophysiology, the common pathophysiology being that in the as the patient's age, there is increase in fat deposition in the liver and in the muscles. There is underlying chronic inflammation, oxidative stress. There is change in the hormones, and all these kind of lead on to there is insulin resistance as well. And all these lead on to decrease in the muscle production and increase in muscle breakdown. So this could eventually lead on to falls and fractures. The patient could lead their independence, could lead on to frailty, hospitalization, and increase in morbidity and mortality, and eventually the quality of life. And as our population is aging, diabetic population is aging, and they are obese, we can understand and we can see how all these factors could have a significant role in causing sarcopenic obesity in our aging diabetic population. And as discussed before, just a few more points to add is obese patients are less physically active, and so are the elderly. As our patients age, they become less active, and this just worsens their glycemic control. There is mitochondrial dysfunction, and as the physical inactivity continues to be there, there is increase in sarcopenia. And this again changes in the insulin sensitivity and glucose regulation. And all this contributes to reduce in muscle synthesis and increase in protein degradation. So how do we detect sarcopenia? What do we do about the sarcopenia? That is where there are several guidelines, including the Asian Working Group for Diagnosis of Sarcopenia. And there are several there is one European guideline as well. What they suggest is to screen for sarcopenia using a SARC-F questionnaire, which I will briefly elucidate in the next slide. And then go on to assess. Once the SARC-F questionnaire is positive, then you go on to assess muscle strength by simple techniques in our clinical practice. And if that is normal, then they do not have sarcopenia. Maybe in a year or two, we can reassess them. But if the muscle strength is low, the grip strength is low, then we suspect sarcopenia. And at that point, we can look into the cause of sarcopenia and treat them. If you really need to confirm or the severity of sarcopenia, then we need to look for muscle mass by various techniques, MRI, CT, DEXA, bioimpedance assessment. And then once the sarcopenia is confirmed, then we'll have to do several other tests for assessing the muscle function, such as the pace, how long it takes for them to walk a certain distance, time up and go test. There are several tests. I'm not going to go into the details because the paper itself is quite elaborate, and it will take at least an hour to discuss about sarcopenia assessment in detail. But this is a basic flow diagram of how we screen, assess, confirm, and categorize the severity of sarcopenia. So this is the SARC-F questionnaire, which looks into the, we asked some of the questions regarding the strength, assistance in walking, rise from a chair, climb stairs, and falls. That's what it stands for, SAR, C, and F. So we ask them simple questions such as how much difficulty do you have in lifting and carrying 10 pounds? And we score them. How much difficulty do you have walking across the room? How much difficulty do you have transferring from a chair to bed? And how much difficulty do you have climbing a flight of 10 stairs? And how many times have you fallen in the past year? If the score is more than 4, then they are considered positive for sarcopenia, and you go on to assess them further. These are the two guidelines that I mentioned, the European Working Group on Sarcopenia in older people and the Asian Working Group for Sarcopenia. And this is, you check the hand grip using a special equipment, and there are special cutoffs for male and female of what they should have achieved to say they have passed the hand grip test. But a simple test, what we could ask them to do is, we can ask them to fold the arms and ask them to ask them to stand from a sitting position 5 times. That's this 5-time chair stand test. So ask them to fold their arms and ask them to stand up from their chair without any support. And if they're able to do that 5 times, in less than 15 seconds, then they have passed the test. And if not, we need to go ahead and assess for them. So time up and go. By the time they, you ask them to from the sitting position to get up and go. If it is taking more than 20 seconds, then it is significant. So if they're able to walk 400 meters in less than 6 minutes, then they have passed the test. So there are several cutoffs to say if they pass the test for sarcopenia or not. So management, good glycemic control, high protein diet. 25 to 30 grams per meal is recommended. Ideal protein recommended is 0.8 gram per kilogram per day. But in order to prevent or treat sarcopenia, you need to give them 1.2 grams per kilogram per day of protein. And that has to be distributed throughout the day and not just one particular meal. Resistance training is very, very important. That can be done at home using different bands, or even filling a 1 liter water bottle and asking them to do some resistance training for their feet and for their arms, upper body. There is evidence that using omega-3 essential amino acids, vitamin D, and calcium supplementation does help sarcopenia. But most of these guidelines and studies, especially, we don't have a lot of data in South Indians, but there is the good work guideline written up by CMC Vellore, Dr. Nitin Kapoor and Dr. Sanjay Kalra's team on assessment of sarcopenia in Indians. But we do not have any longitudinal study or randomized control study looking into which is the best way to assess sarcopenia. We focus more on treatment, detection, and pharmacological therapy rather than non-pharmacological therapy. So there are several limitations to the current evidence we have, but this is something evolving and more studies are being done to assess sarcopenia in our diabetic patients. Diabetic motor neuropathy, I'm just mentioning because this is a very common finding that we see in our clinical practice, where due to motor neuropathy, there is clawing of the toes. The first metatarsal head kind of dislocates, and there is very prominent fat pad like in this picture. And there is intrinsic muscle wasting. This is a typical deformity of diabetic motor neuropathy. We can miss this finding if we don't examine our patient's feet every clinic consult. So this patient is at higher risk of developing foot ulcer at this metatarsal head, the foot pad, or when the patient is wearing tight shoes or slippers, they could develop ulceration at these interphalangeal joint. That is all quite deformed. That's because of motor neuropathy. There is intrinsic muscle wasting, and the opposite action of the flexors and the extensors is lost, leading on to clawing of the toes. Diabetic myonecrosis is just mentioned in the literature. It's very rare, occurs in quite long-standing diabetic in patients with microvascular complications. They can present with acute or subacute onset of muscle pain, swelling, and associated tenderness. The muscles of the thigh and calf are most affected. There's no one particular test that can diagnose this. It's more like a diagnosis of exclusion unless you do a muscle biopsy. Non-specific laboratory findings such as elevation of plasma CK, not always found in these patients. They could have leukocytosis, elevated ESR, and C-reactive protein. MRI imaging could help. The treatment would be to use aspirin, clopidogrel, and NSAIDs. So the key take-home messages from today's talk is that musculoskeletal disorders often cause pain and disability, and we often overlook these conditions because we are so wound up in preventing micro and macrovascular complications, meeting the target, HbA1c, LDL cholesterol, blood pressure, and so forth. We overlook the pain and the disability the patient is undergoing, and sometimes the patients do not attribute these findings to diabetes, and they often end up seeing a neurologist or an orthopedic surgeon. So we see patient from different pathologies rather than seeing a patient as a whole. But we should understand that musculoskeletal disorders adversely affects the management of diabetes, because the patient could be limited by pain and disability, and this could make it difficult for us to encourage them to exercise when we have left it too far and the patient has developed an ulcer or a deformity. So the patient does not get to exercise, the diabetes control worsens, the patient could develop sarcopenia and falls, fracture, and so forth. So one thing could lead on to the other. But if we pick up Charcot's or osteoarthritis or gout at an early phase, these are conditions that can be managed when they are on the acute phase rather than when they have presented very late. Fibroproliferative disorders may cause upper limb disability and may interfere with insulin administration technique. So if your patient is refusing to take insulin, always look at their hands to see if they got rheumatoid arthritis, if their technique is not right because of either hand tremors, because of neurological problems, or if the patient is not able to hold the pen because of fibroproliferative disorders. So unless you proactively look for these disorders, we might easily miss these conditions. And as I have just presented, the prevalence could be as high as 50 to 60% for some of the conditions. Charcot is a very serious complication, and we need a very high index of suspicion. Remember the risk factors of gout or patients with renal impairment and on diuretics. Type 2 diabetes is associated with low bone turnover and inferior microarchitecture. Skeletal fragility is very common despite preserved bone mineral density. Secondary sarcopenia could result from a complex interplay of chronic and systemic inflammation, immobilization, and undernutrition that result in increase in protein breakdown and reduced protein synthesis in the muscles. And management of sarcopenic obesity, we need multimodal intervention and just not one intervention like improving the glycemic control is going to make a difference to sarcopenic obesity. Thank you very much. I'm happy to take questions.
Thank you, Dr. Vidya, for an excellent, very clear presentation. As you said, it is not a usual topic which we discuss. Now, tell me from the bone, what is the commonest bone problem you see in diabetes? I mean, you said bone, joint, muscle. So coming to the joint, first, what is the commonest problem?
What the patient complains is frozen shoulder. What we come across in clinical practice, even in a pre-diabetic phase, is frozen shoulder. And but what the literature suggests is that joint, the tendon and the tendon sheath deformities could be the initial presentation. But what I see in clinical practice is frozen shoulder.
Okay, is the frozen shoulder precipitated by uncontrolled diabetes or even controlled diabetes they get it?
Even in controlled diabetic, they seem to get because of chronic low-level inflammation. And as I said, even in pre-diabetics, I've seen frozen shoulder. And the usual practice is to try and optimize even the pre-diabetic phase because there is chronic low-level inflammation. And again, as I mentioned, these are the patients where it seems to be recurring. Even when you control diabetes, they could still have recurrence. It can come on the same side, or it can come on the opposite side, or bilateral.
But these people, what precautions or what preventive measures you will advise? Routinely you will advise, or only when they get this you advise?
I do not give them routine advice to look after their, the shoulders or preempt them that they could get frozen shoulder. But I always give them an opportunity to ask questions like, do you have any problems at all? So they could open up and say, or they will end up telling, oh, I'm going to go and see the orthopedic surgeon for my shoulder. And that point, yes, I will say like, yes, this is all linked. And you need to get things, better controlled and glycemic control better, because that could actually make things worse. So even if they're going to have manipulation and anesthesia, it's going to come back if the glycemic control is not great. So I don't actually want them, yes, they will get all these joint problems because it'll be just too much information for them, because we are already loading them with a lot of I know macrovascular protection, foot protection, but always pay attention to their feet and tell them if there's anything odd in their feet in terms of pain or neuropathy. I always ask them about neuropathy. Always inspect the feet in every opportunity that they come in. So I can pick on either gout or Charcot's or dry skin, autonomic neuropathy, motor neuropathy. And then when I find something, I will tell them that your feet is at a very high risk of ulcer and advise them about footwears.
Yeah, advising footwear uniformly is a good practice in a diabetic patients. But the shoulder point, will you advise any specific exercise for the shoulder, even without any problem? Will you advise any, like, cycling we do for foot problems and things like that?
No, I don't usually advise them anything in particular for the shoulder. No, when it's before it happens, I don't usually advise them. If it happens, I refer them to a physiotherapist so that they can do a better job in teaching what exact exercise needs to be done. I vaguely know what kind of exercise needs to be done, but how it's to be done, how often, and repetition of these exercises, I think the physiotherapist or an orthopedic surgeon will do a better job. So before it happens, I don't usually tell my patients anything, but it's on my list of complications that I usually tell my patient is that you can get shoulder pain, but I don't advise them about any exercise per se. I don't know if doing an exercise will actually prevent a frozen shoulder from happening. I don't know if there's evidence for that.
Okay. And what about the occupation? And if somebody who's a writer, who's always in the computer, a diabetic person, will you advise any preventive things, the occupational hazard in diabetes?
Okay, I usually pay attention to how the patient walks in and comes and sits on the chair, and the posture is very, very important because most of our patients complain of back pain, shoulder pain, neck pain, pain everywhere. And we put it down to somatization mostly. They say like because they always complain. We say kai kal kodachal syndrome, but then when we promptly, we ask them about occupation. They could be IT technicians, they could be securities. They could be teachers standing all the time, coming with plantar fasciitis. So yes, trying to get to the bottom of what their job involves, how their posture is, and what exactly they do is important. Carpal tunnel, they can get because of repetitive movements when they're doing using the keyboard. So I ask them to use good support. They'll have to support their elbow, sitting, the posture when they sit, the back and all that. So generally I do explore a bit more when they come in with problems and not just dismiss telling this is all just in your head.
Yeah, but I understand. But for a diabetes, exercise is very important. It's a part of the treatment. So in the exercise itself, you can ask them to involve both upper limbs and lower limbs, brisk walking, shoulder exercise, routinely. Will it help? Because many people, they concentrate only on walking. They forget about the hands and shoulder, and especially the finger movements. So, it's a good advice, to take care of all the joints and all the muscles, proximal, distal, both upper and lower limb, as a general part of, any diabetic care.
Yeah. I strongly advocate them to do yoga, provided they found a good instructor, because again, that helps with relaxing the mind, increasing the flexibility of all the joints as well. So I advise them to do at least some of the yoga postures that can be done without supervision. That again helps,
Yeah, that's a very good point. Now, what about bone, osteoporosis and diabetes?
That is very well documented that type 2 diabetic patients and both type 1 and type 2 diabetic patients can develop osteoporosis and fractures. The type 1 is slightly different category because children, because they have hyperglycemia, they fail to achieve even the peak bone mass. That again could contribute to osteoporosis later on in life. But type 2 diabetic, because we don't see a lot of very young diabetics by the age of 30, the peak bone mass they have achieved. And what happens after that is the dysfunction of the osteoclast and osteoblast. And we see a gradual decline. As I said, there is 1.3 to 1.5 times risk of osteoporotic fractures. It's not as huge as the type 1 diabetes. And that is why in the FRAX risk assessment type 1 diabetes is included, but not type 2.
Yeah. And in an elderly person, the frail individuals, you have a separate chart, especially diabetic frail individuals, what to do, what not to do. Like, falls may be more, the drugs, what they take is important. They may develop hypoglycemia. So all
Yes.
those things are very important in a diabetic elderly person. So routinely, you will have to have a frail chart and advise them, especially what not to do, because they will go for hypoglycemia when they take insulin. Especially they go for walking, it's a big problem. Frequent
Yes.
falls and frequent problems.
Fall prevention is my special interest is again in bone health and in postmenopausal women. We have come to a stage where many of our patients are elderly and they want to be independent, and some of my patients live alone and they are taking insulin. So I advise the family to support them in whatever exercise that they can do. Weight bearing exercises are very good for their bones. So I encourage patients to walk, even if it is for 5-10 minute breaks, but throughout the day, even if they've got osteoarthritis, walk for 5 minutes every 1 hour. So weight bearing exercise is very, very important. Safe place to exercise is very important. So if they are not confident to walk outside the house onto the roads, I encourage them to walk inside the house, around the dining table, or from room to room under supervision. So that is another thing. I do not control blood sugars very tightly in our patients. I do not prescribe glibenclamide. I'm wary of using sulfonylurea at very high doses or insulin. I just relax the control to keep their blood sugars, HbA1c around 7.5, especially in the frail elderly. Falls prevention, yes, it's very, very important, especially in the bathrooms. If there is a responsible adult accompanying, I'll ask them to put extra rails so that they can hold on to things. And also in their bedroom or in their vicinity, no sharp objects.
Very good.
Many
Correct.
times we see the fall, and even if they fall, if they're like, as long as there's nothing sharp, at least we can prevent head injuries. No unnecessary rugs or carpets or ups and downs. Those are simple things that we can correct in our house to make sure that the elderly don't fall. And I still do a DEXA, make sure the vitamin D calcium status is intact. And I treat osteoporosis promptly because I look for osteoporosis in every elderly patient who walks into my OB.
And a word about statin, because all these people, they'll take statin irrespective of the Lipid Association of India. Everybody suggests anybody diabetic, statin is a must. And the statin and muscle, always doesn't go well. So what is your suggestion?
That is true, especially we don't have great deal of evidence for statin use in 75 plus 80 plus, unless there is established cardiovascular disease. I will not use it as primary prevention. Every time I use a statin, I usually start low, especially in our population. And if needed, I will stop if there is significant complaints of myalgia in the elderly.
But what about the anybody above 40 to 60?
Yes, I do have very low threshold to start statin as a primary prevention in our diabetic patients, because in my head, every Indian diabetic is a very high risk of atherosclerotic cardiovascular disease. So I have very low threshold to start on antihypertensive treatment on statin. All my diabetic patients get screened for cardiovascular disease, and invariably, because the cardiologists see a lot of ischemic heart disease between the age of 35 and 45, even if I don't put, they will come back with the statin. I'll at least put on rosuvastatin 5 milligram. They will go to cardiologist, come back with 20 milligrams. So I think because Indian population is a very high risk for atherosclerotic cardiovascular disease, which is going to lead to increase in mortality, I put them on at least on a moderate intensity is what the guideline suggests, ADA suggests, which is atorvastatin 20 plus or rosuvastatin 5 plus. So at least I'll start them on small dose to keep the LDL less than 100 in a patient who doesn't have any other risk factors. But if there are other risk factors like ischemic heart disease, then I aim to keep it less than 70.
Also, if there is a statin intolerance or muscle problem, you can shift to the bemboic acid and things like that, newer drugs, which has got less muscular problem. So that's the one way you can do. The last question, very difficult and challenging problem is sarcopenic obesity. And regarding sarcopenia in elderly person, what type of protein, they always ask what diet I should take. So what is your comment?
That's an excellent question, sir. If I was in UK, I could give you the whole list of proteins that we recommend. In India, though we call patients say that they are non-vegetarians, they eat non-veg, it's no way compared to what the Caucasians eat. We eat like, once in a week or once in 2 weeks, and the amount of protein, the non-veg protein that we eat is very less. The amount of protein in vegetarian diet is, we cannot compare that to beef or pork or chicken that has got very high protein content. What I usually recommend to our standard patients, for that purpose, I don't recommend our patients to go and eat non-vegetarian, but simply increase the amount of protein they have in the diet. So if they're going to have 1 egg 3 times in a week, I ask them to have at least 2 to 3 eggs in a day. I've asked them to have sprouts and legumes and dal on a daily basis, and basically encourage them to have more of milk, yogurt, paneer if they can, and try and take these throughout the day rather than just once in a day. But it's very difficult to quantify and tell them this 1 egg is equal to so many grams of protein. We aim to give 1.2 grams per kilogram. That is a standard recommendation, which is very difficult in our Indian population. But
what about protein supplements? Do you
yes, that
advise?
is where I was about to come. I only give protein supplements when I think their nutrition is really, really bad and they're really not adhering to the diet I'm giving. And the risk of sarcopenia and fall risk is very high. So that is a small group of patients that I recommend protein supplements. The reason being, in my experience, even the protein supplements have got the maltodextrin, which is the artificial sweetener in it. And there is evidence that still that can cause dysglycemia. Another thing is our patients are so hooked onto the sattu maavu and protein powder, they take it instead of a proper meal. They take it in between twice a day and assume that their meal is well balanced. And I don't want to send that impression to the patients that taking 2 protein shakes is good enough. So I will only give to a small group of patients.
Because I asked this question because the branch amino acids, it's very good for
Yes.
especially elderly person, and it can be available only with the supplements, not in the food. The whey protein and the non-brand amino acids,
Yes, the essential amino acids like leucine is all being proposed to be very good for sarcopenia.
Yeah.
And again, all these guidelines are focused more about the pharmacological treatment rather than the non-pharmacological treatment. So basically, all these flax seeds and all these seeds are really good in all this, amino acids and omega-3 that the literature suggests. But I'm not a great fan of protein supplements, and I use it in a very small group of my patients.
Yeah, but in the elderly person, because their nutrition is not adequate, the protein supplement, especially this amino acids group, they normally recommend. And in US, people carry loads and loads of protein in the especially the youngsters, gym going people, to develop muscle mass, they use. In the elderly persons also they do. Only thing, they all should be taken in the water, or not in the hot milk or things like that. So if they take in a hot milk, it doesn't serve the purpose. Those
Yes,
are some of the practical problems in protein. The last question is, you are one point of, just a drive home message for all our people.
Unless you look for something, you're not going to detect it. It's the same with, urine albumin creatinine ratio or retinopathy or any other macrovascular complications. Unless you have a low index of suspicion and look for this complication, you're not going to detect this musculoskeletal manifestations of diabetes in our patients. So every time a patient walks in, I think we should make sure that we ask them, or at least look for deformities, examine their feet for any motor neuropathy or deformities. Preventing an ulcer and deformity from happening is far more easier than correcting or amputation or losing a limb. Basically, screening for all these musculoskeletal deformities, picking it up early, be it sarcopenia or falls or osteoporosis or deformity. Pick it up early and promptly refer to a person who is interested in managing these patients. That is one thing I would say. This is not something as a diabetologist, I'll be sitting on a frozen shoulder or explaining an exercise. I would promptly refer to an orthopedic surgeon who can do his job best.
Yeah, general advice, don't glue to the television, don't glue to WhatsApp, social media. Sitting for a long time is not advisable for any patient, whether diabetic or not diabetic, because this is one of the problems now that nowadays even the children, they glue to the TV and then they don't do any exercise, and the elderly person especially sitting long, also can produce problems. Also their bed also, they should take care of the bed as like footwear. The bed also must be advised. And I think overall, comprehensively, they should take care of their health. Thank you very much, Vidya, for the wonderful talk. Now I have the pleasure of inviting Dr. Nagaraj, cardiologist, to deliver a talk on the 4 pillars of cardiac failure. Dr. Nagaraj, are you there? Nagaraj? Dr. Nagaraj?
Yes, sir, I am there. Am I audible, sir?
Yeah. Please share your slides. Nagaraj needs no introduction. Again, he's a well-known interventional cardiologist from Tirupur, and he has delivered so many talks in our forums. And he's a good academician, good communicator. And over to you, Nagaraj, for your.
Sir, are you able to visualize my slides, sir?
Yeah, I can see. Go ahead now.
Perfect. Sir, at the outset, I would like to thank Dr. Murugan sir for giving me the lovely opportunity to converse and have my opinion about the 4 pillars in front of a valid senior IMA CGP physicians as well as senior doctors. I'm going to straight to my talk, and my talk is on about the Fantastic Four. I think Fantastic Four is about 4 young guys who were teleported to another universe, and where they become a great fighters. So basically, heart failure is a syndrome complex where the heart is unable to pump or have enough cardiac output at a rate commensurate as needed by other tissues. And why is it very important here? Because heart failure is almost a frequent one, or I think patient worldwide, up to 30% of global population will have heart failure by 2025. And it's a progressive disease. It means that patients have symptoms despite treatment. And third and most important is it's deadly. Mortality exceeds most cancers. 5-year mortality of heart failure exceeds prostatic cancer. And how good it is to say to a patient that after detecting heart failure, telling him that 50% only survive after 5 years. It is as bad and more severe than a cancer here. And the treatment wise, it's also too costly for the patient, for the society, as well as for the nation. Of patients because die during first heart failure hospitalization, while survival after second hospitalization is less than 18 months. The only good thing is it can be prevented and it can be treated and controlled. So what are the global disparities in prescription? So why do you want, because since heart failure is a big topic, I just want to deal about drugs and what the guideline recommends for treatment of heart failure, especially heart failure with a reduced ejection fraction. So there are global disparities in prescription of guideline recommended drugs for heart failure with reduced ejection fraction. See, overall 37% of patients are discharged and 34% of survivors at 6 months were on all 3 drugs like RAS inhibitors, beta blockers, and MRAs. And this proportion were very low in low and middle income countries than in high income countries. And patients with specific subsets like women, older patients, patients with new onset heart failure, and patients with chronic kidney disease from low income countries, and patients without health insurance were less likely to be on all these medications at discharge and also at 6 months follow-up. So this is a study from Southeast Asian countries about in-hospital mortality while patients are not being prescribed the active guideline-mediated medical therapy for a heart failure. You see, the mortality, in-hospital mortality in India is almost 8.4%. China, it is around 4.1% maximum, and Thailand, it is around 5.8%, and Malaysia and Philippines, it is around 4.8%. So even with the best of the drugs available at present, the in-hospital mortality is still higher. Why? This is from from study from Kerala, where they were able to have a key finding that guideline-mediated medical therapy for heart failure with the reduced ejection fraction was given only to 28% of the population, and even only 20% received triple therapy. So this is because of the low adherence to guideline-directed medical therapy has made a very devastating effect, saying that in-hospital mortality is almost 7% and 90-day mortality is 11.6%. So why is this clinical inertia? Because we commonly see our general physicians and local physicians are treating outside saying, my patient is stable on current therapy. Why do I need to change? He or she has mild heart failure, so it's better to go on with 1 or 2 drugs. And they're very poor, so it is better not to bombard them with more drugs. And it is inconvenient for them, for the patient also, because the cost is also going to escalate. So is it what as a physician would like to be on their patient? No. We need to understand this natural history of a patient with heart failure. Heart failure is a progressive disease with deterioration of cardiac function and quality. So whenever you diagnose heart failure and discharge a patient, you don't mean to say that you have treated heart failure. You have symptomatically controlled heart failure and the patient needs further follow-up. That is what should be the message given to a patient. Because it is a progressive cardiac injury leading on to worsening myocardial dysfunction. Even in a compensated state, you are not going to have a very stable life, because the natural history of heart failure is always in a deteriorating phase. For each time when the patient gets first time admitted, he is into a long, stable, compensated phase. Then goes for a chronically decompensated phase, and he has recurrent acute decompensations in between such times, where he gets frequent admissions, discharge, he gets readmitted, and finally going on to have his end of life or death. This long-standing stable heart failure is a misnomer, because patients with heart failure always carry a residual risk for hospitalization. Second, a sudden cardiac death risk, even when minimally symptomatic or asymptomatic receiving optimal therapy. What does this mean? So, and extrapolating this heart failure risk into an ASCVD risk. ASCVD is atherosclerotic cardiovascular risk, which we used to treat coronary artery disease. You see, a patient with atherosclerotic cardiovascular disease at a very high risk is considered in a stable cardiac failure patient. So, on the other side, a stable cardiac heart failure patient can also have a high risk ASCVD risk, or the patient can have a risk of sudden cardiac death. So these are the patients, which we mean to say they are stable, but actually they are even at a risk similar to that of a high risk ASCVD. So I think this is the gist which I want to express to every physicians and general practitioners. Heart failure is as emergency and as intolerable, much lower than cancer. So kindly, whenever you treat a patient with a heart failure, kindly see to that he is on regular medications and guideline directed medical therapy. So basically, 2-3 slides about heart failure. What is a heart failure? It is a signs and symptoms of heart failure caused by either structural or functional cardiac abnormality, and it should be corroborated by at least one of the following: elevated natriuretic peptide, or an objective evidence of a cardiogenic pulmonary or systemic congestion. So, but clinically, or this is the echocardiography classification is, we have many five classifications. We have a heart failure with reduced ejection fraction when the ejection fraction is less than 40, with a mildly reduced or mid-range ejection fraction when it is between 41 to 49. Heart failure with preserved ejection fraction when the EF is more than 50%. A newer term with an improved heart failure, that is less than 40% at baseline and a more than 10-point increase from the baseline. That is very important. So clinically, how do you classify heart failure? This is the classification. You see, it can be classified as stage A, stage B, stage C, and stage D. Stage A is a patient at risk for heart failure, like a hypertensive, diabetic, obese, with a known family history of cardiomyopathy. They have not got a structural heart disease or any biomarkers or genetic markers of the disease, but they are at a risk for heart failure. So they come under stage A. What is stage B? A patient without current or prior symptoms, but has evidence of any of the one of the following, like a structural heart disease, like LV hypertrophy, chamber enlargement, or abnormal cardiac function with a reduced LV or an RV systolic function, elevated filling pressure, diastolic dysfunction. Third, an elevated NT-proBNP or elevated cardiac troponin levels in the setting. Stage C, this is the very important one. The most of the patients where we see in our day-to-day practice with heart failure is stage C. Patient with current or prior symptoms and signs of heart failure caused either by structural or functional abnormality. They can be divided into two: one getting treatment and getting going for remission, and the second continuing with a persistent heart failure. And stage D is advanced heart failure, where medications are less used and they are into advanced therapies such as transplant, mechanical circulatory supports, etc. So we have an echocardiography classification, we have a clinical stage classifications of heart failure. What is the major change in recent guidelines of treating a patient with a heart failure reduced ejection fraction? So basically, these are the four pillars in a heart failure. We are going to the topic now. You see, the foundational disease modifying therapies in heart failure are the four. RNA, it's called angiotensin receptor nephrolysin inhibitors, mineralocorticoid receptor antagonists, beta blockers, and SGLT2 inhibitors. So you can stage heart failure into A, B, C, D as said before. And whenever you have a patient with a stage A or at risk for developing heart failure, I think, and without the symptoms, we normally start with the lipid lowering drugs. Second, in all four stages, ACE inhibitors, beta blockers, and diuretics have very clearly shown, except for the diuretic, these two have very clearly shown mortality benefit. Diuretics have shown a symptomatic benefit. And only for stage C and stage D, we have all the four drugs, including ACE inhibitor, beta blocker, MRAs, and RNAs. Ivermectin, ISDN or isosorbate dilated and hydrolysin and other therapies have been on the verge, or they have not been included in the four pillars, but they can be used as an add-on drug. But having all drugs, then what is the current unmet need for guideline here? We need a good primary prevention. We have not good established heart failure preserved ejection fraction therapies. How to prevent progression of a heart failure, and giving drugs, and how the patient's tolerability is, and how to reduce mortality. Finally, what does guideline directed medical therapy gives? It gives less effective for heart failure preserved ejection rather than heart failure. It is for heart failure reduced ejection fraction. It reduces all-cause mortality in heart failure with reduced ejection fraction. Mortality increases with the length and the number of successive hospitalizations. So all four drugs, as per guideline mediated therapy, have shown a mortality benefit as well as a reduction in re-hospitalization. And adherence to heart failure reduced ejection fraction is suboptimal. So these are the 4 drugs, and with varied heart failure condition, this can be used. With the heart failure reduced ejection fraction, up till 40%, all the 4 can be used. When we go into a mid-range ejection fraction, I think beta blockers, ARNIs plus or minus, but MRAs and SGLT2 inhibitors can be used. And with for preserved ejection fraction, now I think SGLT2 alone is being given as a class 2A recommendation for heart failure with preserved ejection fraction. So what does the guideline recommend? So there was a drastic shift in guideline from 2016 onwards, because the initially focus before 2016 for heart failure is a vertical approach. So where the emphasis is on dosage, add each drug on top of others at a time, which delays in reaching targets and active treatment. But after 2016, after probably a paradigm trial, where they move into an horizontal approach. So their emphasis is on prognosis, and where all 4 active drugs has to be given as soon as possible, because there should be no delay, and no delays are no longer acceptable, because mortality is as high as 50% by 5 years. So this is the treatment for heart failure reduced ejection fraction stage C and D. Step 1, first is you establish the diagnosis of heart failure reduced ejection fraction. You address congestion first, because congestion addressing congestion is as important as addressing an acute MI. We are into a program now where time to initiation of IV diuretic determines your mortality in heart failure. I think I have slides on it. I'll just show it back. Whenever you have a heart failure reduced ejection fraction with the LVF less than 40%, you start on RNA, beta blocker, mRNA, SGLT2 inhibitors, and diuretics as needed. So then you reassess, go to step 2, titrate to target dosing as tolerated based on lab reports and health status and ejection fraction of the patient. So still EF is less than 40. So it's called a persistent heart failure reduced ejection fraction. And we go on to step 3. If it is well cleared and EF is more than 40, you treat as heart failure impaired or improved ejection fraction, and you continue guideline directed therapy and optimize on dosing, adherence, and patient education. While you are going into step 3, always consider patient scenarios. Class 3, class 4 symptoms, Black African American, you start with hydrolysin and nitrates, and patients with class 1 to class 3 symptoms, ejection fraction less than 35%, and more than 1 year survival, best go for ICD to prevent a sudden cardiac death. And class 1 to class 3, ambulatory class 4, LV ejection fraction is less than 35, LVB pattern with a QRS more than 150, go for a CRTD. Step 4. Step 5, you reassess symptom and you classify again into whether the symptoms have improved or not. You classify them into a refractory heart failure where they are more treated with devices. So this should be your guideline. This is as per guideline mediated therapy, where you treat the heart failure patients from stage C and D. So once when he is treated successfully, he goes into stage B and NYHA class 4 to class 3, class 2, and he continues to be in class 2. So the last bogey is hydrolysis, because we have all the 4 bogeys like beta blockers, ACT betas, MRS, SGLT2 inhibitors, which have already occupied the first 4 bogeys, and the last one to add is hydrolysin and nitrates. We have other drugs like loop diuretics, digoxin, ivermectin, and CGPCON, which are yet to be filled up, but they can be used as an add-on drugs. So how to treat a patient with a heart failure? Preserved ejection fraction. So for a preserved ejection fraction, EF more than 50%, the first treatment is diuretic. And SGLT2 has been into class 2A recommendation recently. RNA, MRAs, and ARBs can be added, but added as per the patient's conditions. And those with improved or mid-range EF, the first choice is diuretic. The second choice is SGLT2 inhibitors. Others can be added as based on patient's condition and patient's each individual status. So 2022 guidelines for management of heart failure. So class 1 recommendation in patients with heart failure, reduced ejection fraction and NYHA class 2 to 3 symptoms, use of ARNI is recommended to reduce morbidity and mortality. So ARNI has to be added for all patients with heart failure, reduced ejection fraction in class 2 to class 3 symptoms. And when ARNI is not feasible, the use of AC inhibitors is beneficial to reduce morbidity and mortality. And third one is whenever they are intolerant to AC inhibitors because of cough and edema and ARNI is not visible, the use of ARBs, angiotensin receptor blockers, is recommended to reduce mortality and morbidity. So what is the rationale for using ARNI first in a chronic heart failure patient? Why not AC inhibitors as a first choice? The main mechanism by which AC inhibitors act is they inhibit neurohormones responsible for progressive worsening of the heart failure, and they decrease all-cause mortality, but no reduction in sudden death by 16%. They reduce heart failure hospitalization by 26%, and they have a modest increase in improvement in quality of life. But on the other side, sacubitril, valsartan, or ARNIs, they combine with the ARB with enhancement of physiological diuresis with the vasodilatation due to nephrolizing inhibition. The all-cause mortality adds on another 16% when compared with previous ARBs, and it prevents sudden death by 20%. That is very, very important because including patients eligible with an ICD. So your heart failure is reduced, and the visits, emergency ED visits are reduced. Less than 18% require intensive care, and less than 38% heart failure readmission at 30 days. And this all put the patient will have a good significant improvement in the quality of life. Feels 9 years younger when compared to a patient already on AC inhibitors. I think 2021 there was strategy of quadruple instead of triple basic medical therapy, and now we are going to what is called a simultaneous instead of a sequential introduction. We have two types of regimen introduction. It can be sequentially introduced or it can be simultaneously introduced, but this has to be decided based on patient's profile. Okay. So in hospital, initiation of quadruple medical therapy is very, very important because at the time of discharge, when the patient gets discharged on the day 5 or day 7, he should be on at least all these 4 drugs, continuing or at a titrating dose. So day 1 to 4, you start all 4 drugs, but see to that this condition gets settled by a diuretic. You can add on with an ARNI or a SGLT2 initially with the MRA, and then add on with the beta blocker and ARNI. So for the first 4 days, you see that patient at least gets all the 4 drugs. Then from day 7 to 14, you continue ARNI. You titrate beta blocker as tolerated. You continue MRA and SGLT2 inhibitors. By 3rd week, you titrate as tolerated. You keep increasing dose so that they achieve a targeted peak dose. Beta blockers as tolerated, MRAs as tolerated, and SGLT2 to be continued. So by almost 3 weeks, they should be on all drugs at a maximum dose. Can we accelerate the adoption of a new guideline? How common and how good it is to adapt a newer guideline? You see, we have many inventions down the ages, but it has taken significant number of years for it to be adapted so that it becomes a part and parcel of life. Like airlines took 68 years, automobiles took 62 years, electricity took 46 years, credit card 28 years, ATMs 18 years. It takes 10 years for new guidelines to permeate through clinical practice. Can we accelerate and expand this? Yes, should be your answer. So what are the benefits of rapid in-hospital initiation of all the 4 drugs? They have a rapid improvement in health status. They have a rapid reduction in heart failure hospitalization, rapid improvement in the ejection fraction, and rapid reduction in heart failure re-hospitalization. There is an improved use, adherence, and persistence. Because at the time of discharge, when you put on a drugs, we can easily monitor how safe it is, how tolerable it is, and how good the patient is supporting, or how good the drug is acting on the patient. Is there any side effect? If so, you can easily treat and discharge them with a good amount of dose of these drugs. So I think we have to continue. What are the anticipated potential side effects? Hypotension is one because of use of ARNI. You assess the volume status and diuretic dose. Consider spacing medicine during the dose. Discontinue therapies that do not offer cardiovascular benefit, like a catheter and blockers. You stop it. If there is declining EGFR, anticipate an early decline in EGFR of 20%. That will recover, because once when you start an ARNI, initial point is there will be a decrease in EGFR of around 5 to 10, and then it peaks and then it plateaus down. So it is always don't go sudden when you put an ARNI. When the EGFR decreases, don't suddenly stop it. It is a usual thing which up to 20% it is tolerable. Whenever you have hyperkalemia, consider potassium binders and treat. But whenever you want to continue all the 4 drugs, continue until the patient has severe significant side effects. So targeting peri-discharge phase, that is what I said before. Once when the patient is, because for treating any other condition like an MI or for general or a fever or any other issues, you treat the situation, you put on drugs, you wait and watch how the patient responds to these drugs. But in heart failure, it's a different scenario. You treat the acute condition, you put on drugs, you see how the drug acts, and then you discharge the patient. So peri-discharge phase of in-hospital stay is very, very important with respect to heart failure treatment. See, this is what I said. Time is prognosis in heart failure. For MI, you say time is muscle, but time is prognosis in heart failure. Time to treatment initiation as a modifiable risk factor is what I am supposed to speak. I thought I would speak first, because the moment the patient lands up with an acute heart failure to a physician or a general practitioner, it is how soon is acute heart failure decompensation is managed. If you prolong it, it is going to have a critical mortality at 30 days, or its morbidity is going to increase. Or you see this, whenever you have an acute heart failure, because in-hospital mortality is almost 4 to 6%, out of which you discharge patients. Post-discharge vulnerable phase, we have 10 to 30% death or re-hospitalization. That is traveling back to the same hospital. And 30% they go on to form a chronic patients, where the outpatient we have 40 to 50% mortality at 3 months to 5 years. So from the starting till becoming chronic phase, what is all things, because at each stage the mortality is always high for these patients. So this is important. So at time to first IV treatment with a diuretic, or time to first initiation of diuretic to control the heart failure. Whenever you have an acute heart failure, because as early as you control the heart failure, is going to have a wider a good quality of life. Because once when the acute decompensation settles within 6 to 12 hours, you can add on drugs by 48 hours and you can discharge the patient by 5th day with all 3 drugs or all 4 drugs, with aiming for a good titrated dose, so that they get least symptoms, they have a good quality of life. So this is what the first thing, first slide I think I put, because whenever you treat as early as time to intervention with IV fluids, IV diuretic as earlier, the decompensation is going to be less. There is a potential benefit for early intervention with drugs. You miss those opportunities, you treat late, the prognosis is going to be bad. So treating heart failure is not just giving all these 4 drugs, but you need to treat the patient as a separate phenotype, because he is not only having heart failure, the causes of heart failure has to be treated. Because by adding these 4 drugs, you can add on other co-drugs, like when he has an iron deficiency anemia, you can add on ferric carboxyl maltase. or if he has black with heart failure and what is African Americans with blood pressure, high blood pressure, you can add a hydrogen nitrate. If he has a disproportionate mitral regurgitation, you can have a mitral its repair. In atrial fibrillation, you can add an anticoagulants, digitalis, or refer for a pulmonary vein isolation EP studies. If LVB and white QRS, you can have a CRT. If a heart rate is more than 70, you can add ivermectin. If there is persistent congestion, add a loop diuretic along with thiazides. Even with a good amount of control, they 5 to 10% can have going for an acute decompensation while in an hospital. So such patients can receive out omic catable, or they can be referred for LVAD and heart transplant. So early integration of comprehensive therapy, why it is very important, and this is a slide I think I want everyone to have as a take home message, because it's only 4 drugs: RNA, beta blockers, mRNA, SGLT2, which has 5 mechanistic pathways. Angiotensin 2 is blocked, nephrolysin is inhibited, sympathetic nervous system is controlled and inhibited, melocorticoid effects are there, and SGLT2 is inhibited. What does it give? It gives 6 additional years of survival for a patient who is treated as early as before the time of discharge. Why should we start the Fantastic Four simultaneously? We need to see where we are now and how the evidence-based treatment is underused, underdosed, and discontinued. Why we should move forward? 4 independent pathways, favorable interaction, and early benefit for the patient. Thank you.
Very good, Nagaraj. I think you have covered the topics well on time. So now we'll have some questions. You are talking about 4 pillars.
Yes,
I am an old man with old history and old knowledge. You have never mentioned about digoxin. Is there any role for digoxin at all?
So digoxin used only in atrial fibrillations. Whenever you have a heart failure with AF, for AF control, you can have digoxin.
But do you don't use in a heart failure with without less the ejection fraction?
No, sir. The only advantage of giving a digoxin is it doesn't have a mortality reduction. It gives only a heart failure readmission reduction, sir.
Okay. So because your Fantastic Four doesn't include digoxin. But
yes, it's add-on drug. Digoxin, ivermectin, and add-on drugs.
You see, when somebody has got heart failure, who develops hypotension because of the acute myocardial infarction, heart failure, there you cannot give SGLT or ARNI because of fear of hypotension. In those situations, even beta blockers cannot be given because of the low BP. In those situations, can't we give digoxin?
Sir, you mean to say it's an acute or a chronic one, sir? Because in a post-MI ischemic cardiomyopathy, what you are mentioning,
yes,
I think the digoxin increases the chances of rupture in an acute MI. So we
not
don't
acute
give
MI. Post infarction after let us say 6 weeks.
Okay, sir. So I think in specific subsets, as what you say, sir, like hypotension is there, you can have, because it can increase the force of contractility, but doesn't increase your blood pressure at that time. It can still control your congestion or heart failure reduction. But what the book or what we give is, we don't give digoxin unless it is an atrial fibrillation base.
What about finerenone?
Finerenone, sir. Finerenone, I think it's a. We have not started because in heart failure, the patient most commonly goes in for a chronic kidney disease at a late phase.
Yes.
So in those patients we can try, but risk of hyperkalemia and all those things are still there.
No, but actually, in a case of hyperkalemia, where you cannot give spironolactone or eplenorone,
yes,
there you can try, because compared to those 2 drugs, this is non-steroidal MRA can be helpful. But how far it is useful in failure, I don't know. That's why I thought.
No, sir, we don't have studies in failure, sir. So we are not.
Okay, now tell me about fluid therapy in heart failure.
So heart failure
Fluid.
fluid therapy, yeah. So the most important thing is whenever a patient comes with an acute heart failure, we always assess the IVC to see how it is, and we always have a central line to assess the JVP. Based on those things, when the heart failure is, we start with initially 30 ml of normal saline. We slowly titrate based on the pressures and all those things. Fluid therapy in heart failure is both riskier as well as advantage initially, because when he is in hypotension, we can start him on minimal fluids when the patient start taking oral fluids. And when the patient is in heart failure, loading with fluids will always precipitate his failure again. So
And
it's a casual thing.
Yeah. What about the diet? What is the diet therapy in heart failure?
Diet therapy, I follow restrict fluids based on the, because we in an ICU we take into account the amount of urine output plus 500 ml there should be intake fluid. Second, depending upon, we need to reduce salt content. We take a salt reduced food, salt restricted diet. And third and most important thing with respect to fluids in ICU is don't load fluids unless it is indicated. Otherwise, we wait and watch, sir.
And especially in summer, you give diuretics for heart failure.
Yes, sir.
Will you add a potassium supplement? Those days, we used to give pot chlor and things like that when you give diuretics.
Yeah, it is always better whenever you give diuretic, you check your potassium levels once when the patient comes for an outpatient visit. When it is less than 3.5, I will always substitute with the syrup pot chlor or potassium supplements.
To assess the fluid overload, do you ask the patient to weigh the patient every day?
Definitely, sir. In ICU, it can be done because the patient will be in bedridden at a critical position. Once when he is moving or when he is coming as an outpatient, we definitely will do it. We'll assess weight each step.
What is the difference between acute cardiac failure 4 pillars and chronic cardiac failure 4 pillars of the drug?
So acute heart failure is a part of a chronic heart failure decompensation.
Okay. So any change in treatment approach?
Now, no, sir. It all depends how early you decongest the patient, and we can start on drugs.
Okay, fine. I think your final word, take-home message.
And heart failure, telling a patient heart failure is just like telling a patient that he or she will not be able to survive after 5 years. 50% will not survive after 5 years. So it is dreaded as a cancer. But the visceral situation where the patient is or the population is very concerned about cancer, they are not concerned about the heart failure. So they need a much concern for heart failure because it is a progressive deteriorating disorder. It's not, whenever you say a patient is improved, it is not improved per se, but his symptoms are controlled and are compensated. They have a very long, stable, compensated phase. But once when they deteriorate, they start falling rapidly. So it is always better you tell them, we have controlled your symptoms, and not to say that you are normal now and you can get discharged. That should not be.
I think that's a good message. Now, as you said, you don't worry about heart failure, but prevention of heart failure, if there is any underlying cause, it's a must. Now, athletes get heart failure. The drugs can cause heart failure. The comorbid problems can cause heart failure. So all these education is important. The patient should understand what his disease is, and he should carry on what the doctors say. And now we got for refractory heart failure, some devices have come. So I think there are a lot of scope for people with heart failure.
Separate specialty, heart failure specialist.
In fact, I'm the sufferer because my father died of heart failure in 1976, where we didn't have so much of drugs and the newer therapy. Now we got enough therapy, good therapies, good treatment, and good follow-up, good monitoring will definitely make them restricted physical activity, climbing stairs, running, walking. All these things are also important. In a summer, especially when you give diuretics, you must also think about electrolyte imbalance, like hyponatremia can be there and hypokalemia may be there. So these are all some of the things you must watch, and family physicians who give diuretics must be aware about these complications. And even mild symptoms of hyponatremia, you should immediately diagnose and treat properly. I think I thank all the three speakers. Excellent talk, excellent coverage of subjects on diabetes and hypertension, heart failure. I also thank Senthil, then Chokkalingam, all the CGP office bearers and President Abul Hassan and the Dean and everyone who has participated. I'm happy to see about 570 people still here and watching the program. Now I hand over to the Anburajan or Senthil, or because Senthil was missing for some time. Now he's come back now.
Yes, sir. Yes, sir.
Yeah,
Sir,
so,
actually, really, the program was very good, sir. There are few comments in the chat box that you have brought out all the doubts which the GP might have encountered in their practice. So they got the answer for that also. So that is one good reach for this program, sir.
okay.
Yes, sir.
Yeah, that's the job of moderator, no? So
yes, sir. Yes, sir.
Because I could not see chat box questions. The questions were not there in the chat box, what I could see. So I don't know whether that facility is available here, because I can see participants list, summary, reactions, but no
chat box. It is there, sir.
No, for me, I think in my computer it has not come, chat box.
Oh, okay, sir. No problem, sir. And actually, thank you very much for your presence and sparing your time in spite of your busy schedule. And sir, now can I just ask our CGP Joint Secretary to give his formal vote of thanks, sir?
Okay, no problem. And it was a very good program. I think the links you must make it available so that everybody will be happy. And kindly thank each speaker separately by writing a letter so that they'll be happy to have your letter also.
Yes, sir.
And Nagaraj, he's a busy interventional cardiologist. His prime time I've taken for talk also.
Correct, sir. Thanks for your efforts, sir. Now I request Dr. Suresh, our CGP Joint Secretary, to give his formal vote of thanks.
Good evening, everyone. It's a pleasure to take this chance to give vote of thanks to this state conference. First of all, I would like to thank our national GCP team, Dr. Satyajit Vora sir, and national GCP Secretary Dr. Anburajan sir, and Vice President Dr. Gunasegaran sir. And I would like to thank our coordinator Dr. Muruganathan sir. I think if I were an assistant to him in my early days, I would have learned a little bit more from him. It's not I think it's not really a problem. Now he's taking a lot of classes to us. It's very wonderful and very informative. He took the speaker role and coordinator role in this program. It's very good, sir. Very thank you to you, sir. From behalf of Tamil Nadu GCP and from individual from me also, I would like to thank Dr. V. Kumaravel sir for taking the wonderful class of diabetes and pregnancy, and Dr. Vidya madam for taking the classes about musculoskeletal. More than diabetes in pregnancy, but also from the general also. It is a wonderful one. And I would like to thank Dr. S.N. Nagarajan sir for taking the class of 4 pillars of heart failure. It's a wonderful one. And last but least, I would like to thank our all faculties concentrating on this wonderful conference for nearly 3 hours. Thank you, sir. Thank you, seniors and colleagues, and thank you, friends. Thank you all.
Yeah, thank you, Dr. Suresh.
So, Senthil, can we leave now?
Yes, sir. Yes, sir. Thank you so much, sir. We will share the link also, sir.
And the medical council credit points, if you have any problem, let me know.
Sure, sir. Yes, sir. You are always there, sir. Yes, sir.
Yeah.
Yes,
sir. Okay. So please come for our IMA building inauguration on Sunday.
Sunday, sir. Sunday, yes, sir. Planning, sir.
Evening
Yes, sir.
6 o'clock. Evening 6 o'clock. Bring
Okay,
bring
sir.
your
Sure, sir.
Pollachi team also. We'll be happy to have you.
Okay, sir. Sure, sir. Sure,
The
sir.
national president is
Sure.
there, so you can meet them and we can.
Oh, that is a big thing, sir. Yes, sir. Yes, sir. So that
Okay,
elevates the
Sandeep.
function also.
Hope
Yes,
you
sir.
like
Thanks.
the program. Hope you like the program.
Yes, sir.
And,
Wonderful, sir. Yes, yes, sir. Thank you so much, sir.
Thank you.
Thank you.
I did not
Yes.
have even tea, so I'll go have tea and relax now.
Thank you, sir. Thank you so
I
much.
could not go out now because you given me the
Correct, sir.
chance.
Yes, sir.
Of,
Yes, sir.
Yeah. Right. Thank you.
Thank you, sir. Thank you.
Right, Nagaraj. Thank you, Nagaraj.
Thank you, sir.
Thank you, Nagaraj, sir. Yes, sir.
Thank you.
Yes.